I'm Stephanie Rawlinson, and I'm calling the South Carolina Disabilities and Special Needs Board to commission to order this morning. This is our August 19th meeting. It is 10 a.m. Our first order of business is the notice of meeting statement. Commissioner Robin Blackwood will read that.
A meeting notice announcing the date, time, and place of the August 19th, 2021 commission meeting was distributed August 17th, 2021 to appropriate media and other groups or individuals who have requested notification. The announcement and agenda were posted at the Department of Disabilities and Special Needs Central Administrative Office and on the website. The public has been notified that accommodations such as interpreters, mobility assistance, or other assistance will be provided to individuals with disabilities and special needs if requested in advance.
Thank you, Commissioner Blackwood. Next, we're going to do a welcome. I'd like to introduce y'all to 3 new staff members. We have Kimberly Cochran with us. Kimberly is one of our new administrative assistants. We welcome Tommy Windsor as our new legislative liaison. Welcome, Tommy. And Courtney Crosby is our new internal auditor. We're very glad to have all 3 of you with us. We also have a new member of our family. I don't know if you all are aware, but our state director did have a beautiful little girl this week. Her name is McKenna, and we are just very proud of her and think she's just absolutely cute as she can be. And we just wish Constance and she well as they recover at home. Everybody's doing well, mom and baby. As we move on into the welcome, I just want to thank you all for joining us. Those of you who are live here with us, we appreciate you. We are under COVID, obviously, for various reasons, so we're trying to social distance here in our conference room, and we have made some arrangements so that downstairs, if you want to still come to DDSN, there's a conference room downstairs that broadcasts us live down there. So if you like to be here, if you want to address us, we will allow people to come in and address us, but we do ask that if you're going to watch the meeting, that you watch it downstairs. So, with that said, we're going to move on to the adoption of the agenda.
So move that the agenda be adopted.
Second.
Would you have a motion to amend the agenda?
Okay. I think we have to vote first on their motion.
I will allow the agenda to be adopted.
You allow an amendment to the motion?
Right.
Okay.
Matter of fact, I can.
Okay. I wanted to amend the agenda to include we have a hard stop at 12:15 today, so the commission can enter into executive session as indicated on the agenda. And after the executive session is ended, we will resume the discussion on the agenda as presented.
Wherever we're at. Okay.
Yeah.
All right. Is there a second to that motion?
Second.
Okay. We have a motion and a second on the floor. All in favor of said motion and approving the agenda with that change, please signify by saying aye.
Aye.
All opposed? Hearing none, the ayes have it, and we will proceed as adopted. Commissioner Eddie Miller will have our invocation this morning.
Let us pray. Dear God, we come before you asking for your hand of mercy for those with severe lifelong disabilities of intellectual disability, autism, traumatic brain injury, spinal cord injury, conditions related to each of these 4 disabilities. In Jesus' name, I pray, we pray, man pray, amen.
All right, now we're going to move to the approval of the minutes. All of you should have received a copy of those minutes. Were there any changes or amendments that need to be made to the minute?
Unusually speaking, I don't have any again.
How about that?
Wonderful. Christy should she should stand and take a bow.
All right, so do I have a motion to approve the minutes?
So moved.
Do I have a second?
Second.
Motion is second on the floor. The vote is to approve the minutes. All in favor, please signify by saying aye.
Aye.
All opposed, nay. Hearing none, the ayes carry, and the minutes are approved. Let's go to Commissioner updates. Commissioner Miller, do you have any updates for us?
Yes, as the chair of the legislative committee, which you've already referenced, I just wanted to take time to especially say welcome to our new legislative liaison, Attorney Tommy Winslow. So he's in with both feet and hands, and he's ready to go and extremely well qualified. Welcome.
Mr. Miller, Mr. Malcolm.
The only thing I have is really not an update, except to say that we need to call David and see if we can get him into this meeting. He's still waiting.
Okay. Has anyone been able to get Commissioner, okay, it's being worked on.
Thank you.
All right.
That's all I have. Sorry.
That's okay, that's fine.
No new update from me.
Okay.
Nothing for me.
Well, I do have an update. I actually was able to get in, one tour before of regional centers before, COVID kind of hit us and we had to close down visitation to those centers. And I want to just say it was a wonderful visit. I appreciate, folks at the Salibi Center welcoming me. And, yes, we do have some improvements to make, physical improvements and that kind of thing, but the place is wonderful. The people there are just outstanding, and the community there is just amazing. I was really touched by a lot of the patients there and just really enjoyed getting to know them and know the staff there. So I did want to add that in and tell you how nice it was to be able to have those few moments in Hartsville. All right, now public input. I believe we have one person, am I correct? And the name?
Patricia Jennings.
Okay, is she on the line? Okay, we're gonna try to call her.
Hello.
Ms. Jennings?
Ms. Jennings?
Yes,
Hi, this is Christy and the commission from DDSN. How are you?
I'm fine, and you?
I'm good.
Ms. Jennings, this is Stephanie Rawlinson. I'm the commission chairman. We are glad to have you doing public input today.
I'm having a hard time understanding you. It sounds like you're way off.
Okay, is this better? Is this better?
Yes.
Okay, I took my mask off. We welcome you to the DDSN Commission Board meeting. And today we have Commissioner Miller, Commissioner Malfris, Commissioner Blackwood, and Commissioner Lamel with us. Commissioner Thomas is on the phone, so he is listening in and will also be on the phone. Our public input today, our public input rules are you get 3 minutes. And we cannot respond to anything you say, but we can listen. So we welcome you and we will start the timer when you start speaking.
Okay, are you ready for me to start?
Yes, ma'am.
Okay, first of all, in calling commissioners, they need voicemail. Not all people have computers. And a lot of them don't know how to use computers. And I'm not talking about the clients of DDSN. I'm talking about the people that take care of them. The commissioner needs information and retraining to the rights available to all clients through federal and state laws. The directors of each county need to be fully informed and trained with respect to the rights of clients and must be required to make these rights available to their clients at all times. Clients' families are unable to find and hire respite workers. You can call the agencies and they'll tell you they have someone. And then they say, where does the pay come from? And we say DDSN, and they say, sorry, cannot help you. Workers here should be making at least what Walmart makers make. That's $15 per hour. DDSN needs to have training and meetings need to, in each county, so that they, caretakers of DDSN clients, are fully aware of what the client's rights under federal and state law. This should come under the directors of each county like it used to when I worked under the governors, but it does not come anymore. And we really need for directors to understand they cannot just be personal. They need to follow the law. And I also want to say, Mary Pooh was personally asked by me to help update and correct my son's Scotty Jennings behavior plan. Only after our county director, Susan John, refused to do so, I called Mary Pooh and asked her to come in and help. And I know that my name is mentioned in the suit where you fired her, and I will go to court and testify and tell everything that she has refused to do since we have moved here. We worked under the governors since 1979 up until 2002. And I will tell you that my husband was sent to Horry County no less than 3 times.
I'm sorry. Thank you, Ms. Jennings, for your input. And we figure out how to stop this thing. I have a timer. Sorry. Your time is up. And we do appreciate your input, Ms. Jennings, and we look forward to having you with us again next time.
Well, I couldn't understand what you were saying. I don't understand why you can't get through on my regular phone, because I have friends there, and every one of them I asked to call, and they called and was able to get through. And I did give you the number. But like I said, I will go to court on this one if Susan John does not get where she follows the South Carolina law.
We appreciate your input, Ms. Jennings, and we will make sure that that is noted. Thank you, ma'am.
Thank you.
Okay, so we have public input. Is there any further public input? Okay, good. All right, now we're going to head into our business this morning. Finance and Audit Committee is the first item on the agenda. Commissioner Blackwood.
Thank you. In our Finance and Audit Committee meeting this month, we didn't approve or review any contracts, so I have nothing to report this month regarding contracts over $200,000. We do expect to see a fiscal year non-service expenditure by vendor that exceeds the 200,000 K threshold in the next. Pat, would we get that review? I know it ends in July, but the recap.
We provided it at the last finance meeting. I'll send it to you again.
Okay. So. But it's not in here, right? In the packet. Anyway, we do have a good review in our last Finance and Audit Committee meeting. The contracts that exceeded 200K for the fiscal year. So if anyone would like to see that contract list, we did review it in the Finance and Audit Committee, but we didn't get any new contracts to review that exceeded 200K. So that is my update regarding the contracts and reporting, the threshold reporting. And then the other item that we're going to highlight today is the fact that the agency is making progress on the conversion to fee-for-service. There was a public notice sent out yesterday by DHHS regarding the renewal of the Idrt waiver and the intention to have that updated and renewed on January 1st, 2022, which of course plays into our fee-for-service timeline and ultimate goal. So the public notice also indicated that there were going to be 2 meetings where the public, for the public to provide any input on this IDRD waiver renewal on Tuesday, August 25th at 3 o'clock and on August 30th at 11. If anyone wants to attend that public input session that DHHS is hosting regarding our IDRD waiver.
Okay.
So those are the 2 updates that I have from this month's committee meeting.
Thank you, Commissioner Blackwood. Any questions for Commissioner Blackwood before we move forward?
Do we know if those meetings are going to be on site?
They are. You can register. There's a link in the public notice that DHHS posted yesterday, August 18th. The links are on that memo as well as most likely on their website.
Great. Next, we go to Commissioner Malfresh for the Policy Committee.
Thank you very much. I am Barry Malfresh, Chairman of the Policy Committee, and we have a few items on the Policy Committee summary for us to go over here today. The first one is I don't know if David's been able to get on the phone yet or not, for sure, but he was instrumental in this first thing I'm going to propose, which has to do with the bylaws, amending the bylaws for and the Freedom of Information Act, related to the Freedom of Information Act. It's so that we can call a special meeting. Right now it says we call a special meeting in not less than 5 days. And we're amending our bylaws, or attempting to amend our bylaws, excuse me, to make it to where that is a 48 hours that we can call up to 48 hours instead of 5 days. It'd be 2 days or 48 hours that we can call a special meeting, and that an emergency meeting would be, instead of being less than 5 days, would be 24 hours notice. And this is consistent with the Freedom of Information Act. And those codes in the Freedom of Information Act have been updated, by the way, on your, for our purposes here today. But the part of this that we need to discuss for just a moment is the fact that if we leave it like, as I understand it, if we leave it like the language states right now, that we do not have a category for 25 to 47 hours. In other words, that second day, there is no category for. So what I'm recommending here today is that we would make the 48 hours be the 48 hours before the meeting be a special meeting, and that even though the statute says it can be 24, but we can do more than the statute says, we just can't do less. So that's what I'm recommending here today, that the policy committee would, well, actually, this really doesn't come as a motion in a second because we really didn't get this straight at the policy committee. So we really need I'm making a motion that we do that, but we really need a second.
Okay. So the motion is to adjust the bylaws to where it says we have to do 48 hours notice for a special meeting, 24 hours for a emergency meeting, or?
That's correct. And that language is consistent with the Freedom of Information Act. That's right.
Okay.
So anything less than 24 hours would be considered a special meeting.
Okay.
Unless it was a regular meeting, which we hold every month.
Okay.
For anybody, if anybody's confused. I'm not, but I can see where somebody would be. So I need a second on that, and then we need to vote.
All right. Do we have
I'm just confused. So are we presenting this as came out of committee, as what's written down here in paragraphs 3 and 4 under Article 5? I mean, that represents what we voted on in the policy committee. So are we voting on that, or are you proposing a change from that?
Well,
I'm sorry, I'm just confused.
What I'm trying to say is that in the policy committee, as me and the staff both were confused about, was what would we do between 25 and 47 hours based on what we voted on? Because we don't have any, there is no definition for either one of those for 25 to 47 hours. So we're trying
Obviously, I think that was intentional. because originally as proposed, it was supposed to be that a special meeting could be called with just 24 hours notice of time. An emergency was less than 24. But, and I don't want to speak for Commissioner Thomas, but I think that my recollection was the same with him, that we were a lot more comfortable that special meetings had to have at least 48 hours notice. So there is no provision.
I'm here, Mr. Chairman, I'm here, and that is my understanding also, just what you said.
So it's written in the minutes correctly, correct? I mean,
And the proposal correctly, yeah, I mean, and there is a gap there, but I think that was intentional, that we
So what do we
that
call?
unless there was extreme circumstances where 2/3 called, that basically there is no provision for us to have a meeting in less than 48 hours, unless 2/3 of the commission voted for it.
So then you're asking that we leave it as 24 to 47 hours has no name.
Sure. In terms of, was there a need for it? That,
We could call it either emergency or special. We could call it an emergency meeting with 47 hours. But we need to call it something. So why don't we just call it an emergency meeting within 47 to
sure, if you want to call that, sure, certainly we can do that.
25 to 47? Okay.
Certainly that would be fine.
Okay, well, let's do that.
Where will we amend, what will we amend on this document?
I'll amend my motion to say that an emergency meeting will be 25 to 48 hours, or 47 hours, and that special meetings will be more than 48 hours in advance.
I think, just to clarify, Barry, I think what you're talking about there is that emergency meetings is anything less than 48 hours.
I'm sorry, yeah, that's right. I'm sorry.
So so the second paragraph of Article 5, number 3, would say that emergency meetings and conditions are those announced less than 48 hours before the meeting.
Okay, that's easy.
Is that?
That's right.
So it's
Okay.
just two-word change.
That's fine.
Okay, so the two words changed in what is proposed is in the parentheses, those announced less than 24 hours.
Those announced less than 48 hours would be the new language.
Okay.
Yeah, so those announced less than 48 hours
Okay.
before that meeting.
Would be an emergency meeting.
Would be an emergency.
Got it.
We need to make sure this is straight for the bylaws purposes. Everybody, we sure we have this?
Yes.
Okay.
All right.
Okay, so that's my motion, and we need a second, because like I say, I don't think
I'll second, this is David, I'll second the motion.
Okay,
Thank you.
very good. All right, so we have a motion and a second. Any more discussion on this matter? All right, hearing none, we're going to go for a vote. All in favor of this adjustment to the bylaws, please signify by saying aye. Opposed, nay. Hearing none, the ayes have it, and this adjustment will be made to the bylaws for DDSN.
Okay, we have a second bylaws adjustment, simple bylaws adjustment under Article 5, under meetings. It should say that we were asking, that the policy committee is asking that the chairman would be, that it would say that the chairman may approve the agenda for a full commission meetings. That gives two options for people to approve it, not just the executive director, but the chairman as well. Which is something that should have been in there a long time ago, but I think, but anyway, that's it. That's the second. That's my next motion regarding changing the bylaws, and we all understand that takes a two-thirds majority, but we just had a unanimous decision.
So it came as a motion and a second out of committee?
That would come as a motion and second out of committee, yes.
Okay, then we have a motion and a second. Is there any discussion on this matter? Hearing none, we're going to move forward. All in favor of this motion, please signify by saying aye. Opposed, nay. Opposed, nay. Hearing none, the motion carries, and that adjustment will be made to the bylaws.
Okay, the next item on the policy committee is thank you very much for those, and I apologize for taking so much time with that.
No problem.
But we needed to get it straight. I felt. And the second thing, the next item on the agenda for the bylaws is the outside employment, something we've been through many times. I'm going to read this again for the record. And by the way, I would ask that this was put in the record, that what I'm about to read, which is regarding the outside employment policy, so there is no ambiguity about what this says. The purpose of this directive is to prescribe the guidelines by which DDSN will request and obtain approval for outside employment. Where outside employment creates the appearance of impropriety, conflict of or special interest, interferes with employees' ability to perform DDSN job duties satisfactorily, DDSN maintains the authority to disprove such outside employment, withdraw approval of such outside employment, and take appropriate disciplinary action up to and including termination. Said that many times, but I think it needs to be said again, and it would be nice to in minutes. But anyway, other than that, we have gone through this again, and for I think the fourth time now, and and our Constance is on board with what it currently says, and our policy committee is currently on board with what it currently says. It made a few changes that y'all can see in y'all's book, primarily to make it to where somebody could accept the job, and then we would decide within 30 days whether they could continue to have that job, was the primary adjustment, but there was a couple other small ones. I don't see the necessity in going through all of those adjustments the policy committee did, and we are very happy with it, unless somebody would like to. But that would come as a motion and a second out of the committee, because we were unanimous in that decision.
All right, is there any discussion on this matter? No discussion? All right, well, we will move forward. Those in favor of this change to the bylaw for outside employment, please signify by saying aye. Aye. Opposed, nay. Hearing none, the ayes carry, and that policy is approved.
Yeah, the last couple of things is an update for the policy committee relates to the fact that we have changed our the policy committee directive. We're not going to vote on that today because the rest of the committees have not gotten their directives in order yet for us to be able to make any changes to the policy, to any of the committees' directives as yet. We would ask that the rest of the committees would do the same to go through theirs, and we won't vote on this until everybody does theirs, which hopefully will be in the next meeting. But we do have to have each committee does have to have a meeting in order to do that. So at some point, the other standing committees need to have a meeting to do that.
Do the chairman feel comfortable, of the committees feel comfortable they would be able to do that for next month?
Yeah.
You feel comfortable, Eddie? Okay, we'll put that on the agenda for next month then to approve those. Okay.
And then the last thing is that there is three directives that will be posted for external review for the public comment by the end of this month. It was three policies, 50210DD, 70003DD, and 73801DD that the policy committee has previously put out for the staff to correct. So that was the only other thing. And we also and the last thing, I'm sorry to miss so many things. The last thing is that we have referred the video surveillance camera policy to the new committee that was just created for ICFs. And when they come back with their recommendations, then that will come back to the policy committee for consideration. Okay. And that's all I have for today.
Well, thank you, Commissioner.
I didn't mean to take up all of y'all's time.
That's all right.
Sorry.
I appreciate it, Commissioner Masters. Thank you for your input and for your committee working so hard. Now we're going to talk about the special committees and task force updates. please remember, Chairman, if you are in charge of one of these committees, if you add a new member to that committee, we would like to get their information, their contact information. I know Commissioner Miller. Do you remember the gentleman we met in Florence? Do you have his contact information?
Mr. Holt, I believe his name
Yes,
is.
you have that. Will you get it to me and Commissioner Lamel, if you don't mind?
I don't know that I have it, I'll double check.
Okay, I've got it somewhere if you don't, but anyway, let's just touch base about that. And if you do add a member to those subcommittees, we would like for you to bring that information to the board just so that we know who's on the committees. And that way Christy can keep a master list for us. I know we had some people asking who serves on what task force and that kind of thing. So I think we will try to put that somewhere so that people, when they ask, we will have that information at hand, if y'all don't mind. Okay, so
Are we putting that on the website?
we could, do y'all feel comfortable doing that? I don't know that we need to put their contact.
No, just their name.
Just their names. I don't think we need to put their contact information on there, but do we need a motion to do that? Since this is, we just make that decision.
I suspect you can do it as chairman. 'Cause you
Okay,
created
well,
the-
as chairman, then I'll put their names, I won't put their contact information, but, obviously we'll be able to reach them if they have something they want to ask them or whatever.
Do you want to comment on the, how the minutes will be taken?
That's the other thing. Please, while those decisions are not made in those meetings, we're just putting together ideas and that kind of thing. So those meetings really aren't broadcast. They're working meetings more than anything. So those meetings are not broadcast out to the public. But we will allow people to come in and watch if they want to, but we're trying to limit the number of people in the conference room. So we ask you to sit downstairs and watch us if you want to watch. There's no public input to those committees other than the people that are on the task force. However, minutes will be kept in those meetings because there are commissioners present. And those minutes will be kept at DDSN, and I guess they'll post those minutes on the website as well. So, but yeah, they'll post those minutes so that we have that. Okay, let's begin. Commissioner Blackwood, tell me how the Autism Task Force is coming.
We had our first initial meeting with just DDSN staff about the task force, the goal, the purpose, and had a good discussion on, how to start this process of identifying our biggest challenges and trying to work as a team on trying to resolve some of the issues facing people with autism that we serve. We hope to have our first meeting in September. That's not been set yet. We do have, I can share the names of the task force so far, and we'll add any new names to that as we go. Of course, I'm the chair, and then DDSN staff, Rufus Britt and Daniel Davis will be a part of the task force, as well as behavioral analyst Jody, I think it's Chloe Wiki, maybe? It's her last name. And then we have Margie Moore Williamson of the ARC of South Carolina, Carol Page, South Carolina Assistive Technology, and Susan Sachs of Project Hope Foundation, and Patty Wilson of Sumter County DDSN board. So those are our current members of the task force, and that's my update for today.
Wonderful. Thank you so much for that.
Yeah.
All right, Commissioner Malphurs, anything from the Communications Committee? I do want to thank you all for the chairs. This is so nice. I don't feel like I'm turning over our old chairs. I felt like anytime I moved, I was going to turn the chair over. So thank you. We finally have chairs that feel like they're not going to turn over on us. Whoever took care of that.
We appreciate our IT department for taking care of that particular problem for us after our discussions. And we appreciate all of the things that we have been able to do so far. We do have another meeting this coming Tuesday for that communications committee. Okay. And so we'll discuss more about what we decided at the next meeting for that and that meeting.
Okay, Commissioner Commissioner Blackwood on the FMAP.
Yes. So we have set our first FMAP subcommittee, or I think it's more of a steering committee is the official name of that group. And our first meeting of that group will be September 1st at 2:30. And the members of the FMAP oversight are DSN CFO, Pat Malley, myself, Commissioner Eddie Miller, Michelle Woodhead of Rock Hill is a family member representative, Don Johnson of, she's an executive director at Lawrence. Thank you, Rufus. And Craig Bird of CHS Group, South Carolina. And then our new internal auditor, who just started this week, Courtney Crosby is our final committee member. So that's my update on that. And obviously, when we
Start to gear up.
Yeah. We have our first meeting, we'll be able to report back.
Good.
Anything
Look forward to hearing from you guys. We're excited about that moving forward. I am the chairman of the ICF Reform and Improvement Task Force. We had our first meeting yesterday. Lasted about an hour and a half. Great, well attended. We had some folks online, some folks actually came to DDSN. Was a great meeting. What we did was we started our brainstorming session. We came up with our top six things that we think need to be addressed in ICFs. A lot of things fall under those six, but it was 2 pages of brainstorming ideas. So I think we're headed in the right direction with that. We just appreciate everyone being on it. It's a huge task force because all of the facility directors are on there, several DDSN directors are on there, private providers on there, parent groups are on there. So it's a very large task force, and but it's going to take a lot to do what we are trying to do to the ICFs. So we do appreciate everyone being involved in that. And our next meeting is the Wednesday before the October DDSN meeting. So we got 2 months to really work and get our stuff together, and we'll be presenting some plans together, hopefully in the near future. Training and task force, y'all haven't really got started yet, have you?
We have not had a meeting yet, in part because of the, as was discussed just a moment ago, some contact information that we need for one of the designated members. There's also was an issue where one of the individuals from the Department on Aging that we were hoping would join us based upon their work on the memorandum of understanding that we received information on. She's left the Department on Aging. However, I did reach out to the Ombudsman, Ms. Dale Watson. The initial reaction that I got was very positive as far as joining that. I'm waiting to hear back from her on that. And once we have established contact with Mr. Holt, and I hear back from her, we'll schedule that meeting. I expect that to be sometime in early September.
Wonderful, wonderful, thank you. And we'll try to get all that information to you. Yes. Wage, Equity, and Parity Subcommittee, that's Commissioner Thomas. I know we've got a lot of folks working on that, don't we, David?
We started off, I think, really about a week ago when you and I talked about how to organize. And we're looking for folks that want to get involved out that are listening to us right now on this wage parity issue. We have found as we went around the state about a month and a half ago or so, a month ago, there was a lot of talk about that, and in the world that we see today, you know, where you can get a job at McDonald's for $15 an hour, that it's has created a wage disparity, particularly for the professionals, the nurses, so forth and so on. So I'm looking for folks that want to give us a call and make contact with us. If you want to be on this commission and you have some kind of a nexus or connection with DDSN and have some information. It sounds to me like, in listening to you all, you're trying to suck up all the great people, but I know there are lots of folks out there that are still available to my commission, because I think it's going to have quite an impact. We'll be having probably, and I've asked the Chairwoman Stevenson to get in touch with staff so that I will know who the right people are on staff at main headquarters to sort of help me coordinate this. So if, I just need some contact there. And I suspect our first informal meeting will be sometime around mid-September. I've got a couple of, the reason I'm not there, I've got a couple of medical issues going on. So I'm having to sort of be ready to shift times and that sort of thing. If y'all be patient with me. But I think the first informal should be around mid-September. Thank you.
Great. Thank you, David. Look forward to working with you guys. I do want to remind you, commissioners, while we all are assigned task force and that kind of thing, we have to be real careful as far as going to these meetings if you're not on the task force, because of FOIA and because of requirements for called meetings of the commission, that kind of thing. Only 3 of us can be present at any one time. So just be real careful. If you're not a member of a task force, please don't go unless you're sure one of the other commissioners is not going to be there who's assigned to that task force. Okay.
Let me ask you a question. Could I ask just a quick question about that FOIA issue?
Please do.
Yeah, because I think we almost need to have a sit down to kind of fully comprehend the nuances of that. Let's suppose, for instance, that I was interested in what Gary's doing, and they've had a couple of meetings, and I make a phone call to him, and if there are 2 other members of the commission, and I want some information, and he tells me basically what's been going on. Is that then? I mean, is that something that we need to be careful for when a person is inquiring and receives information from another commissioner about what they have done? Does that pass the magic point?
Commissioner Thomas, we're honestly not 100% sure on a lot of the FOIA stuff. I've been asking attorneys all week to explain that to us. I know that our training group and our administrative team here at DDSN is working very hard to try to get us a FOIA training so that we understand the ins and outs of FOIA and have a complete understanding and have an attorney here that can answer those questions for us. Until then, I think it's best, until we get that information in hand, I think we err on the side of caution and just make sure that only 3 of us are there. I think if you individually call someone to ask them what's happening, I think you're okay, but just don't have more than 3 of you involved, if that makes sense.
Well, if for some reason you did, then is the nexus to, I mean, if the point was to notify the public and to provide transparency, which is, and by the way, I was 6 years on Greenville City Council, and I mean, we I guess I should know the answers to all this, but it is, as we have heard, nuanced very, very severely, and the legislature is immune. I mean, they don't have to worry about this kind of thing. That is,
right.
Having a majority outside and not having called a meeting and made that available to the public and so forth and so on. So I think it's a very interesting legal matter, but it does sort of make you wonder exactly how functionally it should work. And I mean, nobody wants to accidentally step over something and then find themselves somebody questioning whether or not they did the proper thing as far as freedom of information and whether the public was alerted. So my point is, if you've noticed the public of a meeting that you're going to have, and they can come to the meeting if they want, it's kind of like workshops, when county council members or city council members do a workshop, but public is informed, public notice is given, the public's not exactly invited, but the media is invited. And I've been to Lord knows how many of those over the years. I'm not talking about the legislature. I'm talking about city council when I was a councilman. Does that satisfy? I guess there's just a lot of questions that I have too. So the idea of a workshop might be a good idea so that we can brainstorm, exactly where the landmines are.
Yes, I think we are going to actually do either a training or a something for this commission in the next month or two on FOIA specifically, because this commission has never received training since I've been on it regarding FOIA. And so I feel like that's something we need to address. I think Robin said the same, that she had not ever had any FOIA training. And so I think that's something we're going to have to address. And that, obviously our training department will work on some of that and get us some training set up on that matter. Thank you, David. I appreciate it. All right, let's go back.
Chair,
Yes, sir.
I think probably what you need to do is look at our bylaws
Yes.
and see what our bylaws say as it relates to a quorum. Because that will further help us define where we.
Well, it does say that the bylaws does say that our quorum is 4 people of the 7. If there's the 7 commission, it's a majority of the commission. So relating to what she's talking about 4 people coming to a meeting, I don't think there's much question that we can't have 4 commissioners in a meeting, because that could be considered a commissioner's meeting. And so, but these other things are not directly addressing for you, except to say that if there's anything that if there's anything that we have in our bylaws that supersedes FOIA, that FOIA supersedes our bylaws. So that's what we have to remember about that. So that's why we have to get more of the training on FOIA. But there's no question that 4 members of our commission should not be in the same room at the same time at any meeting, because that could be considered a commissioner's meeting.
I think we just probably need to look at it also from the perspective of electronically.
That's right.
Okay, because we may need to kind of.
We receive meeting notices and that kind of thing, and all of us are sent the mail, and we all respond, yes, we can do that, no, we can't do that. We've got to be real careful, and that's something we've got to look at and figure out, because that's very, very confusing.
It's just a matter, I think, of realizing that as public officials, that anything we do in our capacity is subject to FOIA. Those emails are subject to FOIA. That's why we set up DDSN email addresses so that we can trace them easily. Yeah. So we're talking about a couple of different things. FOIA is information that is accessible to the public, regardless of whether it's in a meeting or not.
Right.
Conducting meetings without proper notice is a separate issue from our communications that are subject to FOIA. And I think that the issue that we're trying to address to make sure of is that we are not conducting meetings illegally.
Exactly.
We come under state laws.
That's correct.
FOIA is what we come under.
But it's state laws, because you have state laws with FOIA.
Oh, that FOIA is a state law, yes.
Right. What we have to do is examine that and see whether or not we fit within that frame. That's right.
When we have the FOIA training, we will revisit the bylaws again.
Yes.
To see if there's some things we need to put in there. But as of now, it says that anything in FOIA supersedes the bylaws, so it's covered at the moment. But we do need to clarify some things, and we will.
I think so too.
There's been a lot of work that we've tried to do on the bylaws, and we will, before I'm off the commission, I pray, have it straight.
We need that. I think we need some clarification.
Which, by the way, for those listening, I plan to be no time soon, so don't be happy.
The only thing I'm saying, though, Madam Chair.
Yes, sir.
We need to reach out to the state, okay, and then have them to come in.
That's right. Who's the state? State's lawyers.
State law.
Yeah, the administrative committee, the state admin office will be part of that with their lawyers and come teach that. So that's who we will be reaching out to. Yes, sir.
So an announced workshop meeting where you're not having any business conducted is still considered a meeting if you have 4 members present.
That's how we understand it, yes.
That's how we're understanding it at this point.
You said actually we're not doing any business.
We're not,
right.
But we have to be careful. We're in the same room.
Because there's 4 commissioners present, so that could be considered a commissioner's meeting.
And if the 4 commissioners present reach a consensus on action and then go ahead and bring it forward and
right.
vote on it the same way here, that decision has been made not at the public meeting, but at that previous event.
Even though there was no
That's-
vote taken or anything done.
It doesn't have to be as overt as we're going to vote this way.
It's very
It
complicated.
certainly limits input as far as understanding what's going on in the whole committee.
I know.
It limits us in many ways, and that's why we have to get clarification. You're right.
I'm sorry I was here yesterday.
No, it's no problem, no
Madam Chair,
problem.
will we-
Have the training, so.
I attended Robin's meeting and I was the 4th commissioner there for the finance meeting. I mean, I didn't add input, but I was there listening. And we didn't vote on anything, I didn't vote on anything, but still, I was there. So I did it too.
But I think to be in a board where I can't participate and understand what's going on, it doesn't seem like that's reasonable.
It doesn't seem reasonable to
Madam
me.
Chair,
Yes, sir.
I think that's time for another discussion. We need to bring in the experts before we.
Let's move on in
Get too far into that.
let's move on the agenda then. All right, let's go to old business. The status update on the transition plan for conflict-free case management. Lori? Hey, Lori, welcome. Glad to have you with us this morning.
Thanks. So I'm here today to kind of give you an update on conflict-free case management. If you guys will remember, back in April, you approved a directive related to conflict-free case management that basically sets forth within our system that the same person can't receive direct services and case management from the same provider, okay? So as part of that directive, effective June 1st, we stopped people from entering conflict. So as of June 1st, 2021, any new person who enters into a conflictual situation is transitioned out of conflict within 60 days. But we had the business of people who were already in conflict. And if you'll recall, part of the directive is a transition framework that was approved by the federal government in each of our waivers for us to transition all people currently in conflict out of conflict by December 31st, 2023, right? And it's like a percentage plan. So some of the things that we've been doing around the transition is during the month of June, every provider was provided a list of people who DDSN deemed potentially in conflict, right? We had some lists, we weren't sure about them, but we kind of gave them out and said, here's who we think you have in conflict. We want you to provide us who actually is in conflict and for which services, along with a transition plan for that provider to meet the transition framework. So all of those transition plans and lists have been sent back into DDSN. They have all been approved. And we have developed a statewide list of people who are in conflict and a statewide transition plan that basically says that we are going to monitor the benchmark dates that are listed in the approved framework within the waivers. The good news is we really didn't have to go back to providers to ask them to tweak their plans based on the way that naturally our network was going to transition into conflict-free. We are going to make the benchmarks, right? So we didn't have to kind of go back and say, no, that won't work. We also have learned that there's one more provider that intends to completely divulge itself from case management, like they're not going to provide any at all. Every other provider's transition plan ends with that provider continuing to do case management in their area. They just won't do it for people that they provide direct service to. So that's kind of good news, right? Just some information about where we are now. The initial transition framework that was approved in the waivers identified 5,752 people who were in conflict, okay? So those benchmark numbers, 20% by December 2021, 50% by December 31st, 2022, and then 100% by 2023 are based on that 5,752 number. As of today, we actually have 3,724 people in conflict. So we've already done a 35% reduction. So we've already met kind of our benchmark that is due on December 31st of 2021. And we have about 15% more in order to meet the benchmark for December 2022. So our system, that's a product of some providers kind of getting out early because they kind of saw what was coming, and then other providers are doing things like, if they have a case manager who's been there for many years and that case manager is going to retire, instead of rehiring a new case manager, they're just kind of identifying the cases that would be conflictual and going ahead and offering a choice of alternate provider. So the other thing, those numbers that I just gave you are all Medicaid numbers, okay? So all of this kind of stems from a Medicaid requirement around conflict-free, but when we wrote our directive, we wrote it so that no one in the DDSN system would be in conflict. So there are an additional 190 people statewide who have state-funded services that will also be, they are part of this transition framework. We have them on a list. We just didn't give that list to Health and Human Services. So are there any questions about conflict-free case management that I can answer for you guys?
We are going to meet the deadlines then, correct?
Yes.
I know before we had concern about that, and just want to make sure we are.
Yeah, I mean, the way that so what will happen now is we have the list that's statewide. We have it sorted by provider. Our intention is to do two things. So by the end of August, we're going to send out a statewide informational map to providers that says, in York County, there's this number of people. In Chesterfield County, there's this number of people that are going to have to be resolved. Because that'll help providers plan expansion. They can look at it on a map and say, these counties are adjacent to me, and maybe I want to, go into these. So we're going to do that. The other thing we'll do is the list that we got back from providers that said these people are in conflict. We're adding a couple of kind of columns. It's Excel spreadsheets, right? So we're adding a couple columns that we'll give back to that provider, and we'll say by December 31st, 2021, we need to know any updates on these people. So we're going to have kind of a constant tracking of folks. I will report to you guys periodically where we are with conflict free, but at this point, I'm pretty positive that our system is moving in the right direction, that providers have good plans about what they're going to do with those folks. And we just have to make sure that we continue to provide technical assistance to the network to make sure, the biggest worry in all of this is to make sure there's no break in service for anybody, right? If we have to move somebody's case, we don't want it to look any differently in their direct service provision, because we do that.
Right.
You got a dog.
I was excited about it. Let me say, since we started case management fee for service a couple of years ago, right at 2 years ago now, I think. There has been, we have had approximately how many people get out of the business of case management? How many?
So I don't have the number on me, and I hate to give you a number when I'm not sure of it, but I can get that for you. It's a handful,
A handful of people, and we've had no problem getting people to take over those cases, correct?
We have not had a situation, we have not had a problem with an area that's underserved to this day. And we've had some rural providers get out of the business, so those are the ones you worry about. Is somebody really going to want to go into one of the counties that's more rural and there's not a lot of stuff right around them? But we've even had coverage in those areas. The thing with the transition plans and the carefulness around which we do things is, providers who are willing to take new cases obviously can't just take them without preparing. If I have one case manager and I'm willing to go to a certain county, it doesn't mean I can take all those cases in that county in one day, because I might need to hire new case managers, right? So that's the purpose for this transition plan and trying to do it over time, we really don't want providers to just be doing 100% of people one day and doing 0% of people the next day. It's not good for the people that we serve. It's not good for the case managers. It's not good for the providers that are willing to accept those cases. The best thing I think we can do as a system is to make sure that we're really open and honest and provide as much information to people as we can so that they know what's coming, which is why I said we're kind of working on this map. Our intention is to get that memo out by the end of the month so that providers can kind of see the first transition from these cases will be around December. So it'll give them a couple of months to kind of see, hey, these providers. The other thing that we talked about, I have a case management work group that meets monthly, and they're a really great group of providers that provides kind of some feedback for us about how we do things. And one of the things they brought up yesterday was they would like to know about the counties that they're interested in. And it's kind of impossible to put that in a form. But what I said to them was, if you're a provider and you're interested in going into Barnwell County, right, you can call us and we can talk to you about what their transition plan is. Because the truth is, some of the transition plans are not to offer a choice of alternate case management providers. In some of the transition plans, they're going to look at alternate direct service providers. So, when you get down into the weeds, we really just have to talk to providers about areas that they're interested in going into and kind of what's there.
And the primary point is that those who stood in this room a few years ago and said that the sky was going to fall if we went to fee-for-service and case management were absolutely, unequivocally, without question, wrong, just for the record. The sky is not falling, the sun is out, everything is going good for case management.
All right, Lori, is there anything else?
So I have the next agenda item. There's nothing else about conflict-free case management unless you guys have any other questions.
Thank you.
So the next agenda item is just kind of some information on the Idrt waiver renewal. As Commissioner Blackwood said during her position, the renewal has been posted for public comment on the DHHS website. I fully anticipate that it'll be on our website very soon. That tends to be what happens. Like they post it, then they send it to us, they send it to Family Connection, and we get it posted everywhere. I'm really excited about the renewal because I think that we've been able to work cooperatively with the Department of Health and Human Services to make some significant changes that will help us as a system and will help in service delivery. Just a few of the things that are in there, because it is open for public comment. I think public comment closes on September 19th. So I encourage you guys to review the document, to look at the stuff that's in it, to make comments, to attend those webinars, to be talked through. But some of the things that are in it is we added in-home supports to the ID waiver. In-home supports is a service that's currently in CS. It's self-directed. We've been able to do a lot of flexibility with in-home supports during the Appendix K authority around all the waivers during COVID. So that's kind of why we're adding it. So I'm kind of excited about that. We're looking at adding an independent living skills service, which is a more one-to-one community-based training service versus people getting that type of service in a center-based setting. Adding remote supports as part of assistive technology so that people, we can kind of come into the most current technology services for people. Tiers for residential habilitation, which is huge when we start talking about fee for service in residential for DDSN. Some different options for respite, maybe a daily rate for residential respite, and then some options for multiple people receiving respite at the same time in the same household. As well as looking at a differing rate between business provided respite and self-directed respite because the overhead really is different. Adjusting the environmental mods cap, it's basically doubling in the renewal from $7,500 lifetime to $15,000 lifetime. Updating and kind of modernizing the career preparation service that's in the waiver. And then just enhancing some of the quality oversight and quality management. We worked a lot on performance measures and actually being able to measure the basic assurances that are in the waiver. So do you guys have any questions for me about that? All right, thanks for letting me be here today.
Appreciate
Okay.
it. Good information. All right, our next is Ms. Janet, a status update on the Hcbs transition plan.
Good morning.
Morning.
I think the information that I'm going to present is in tab 7 of your binders. At least that's what I'm told. I'm here to talk about the home and community-based settings rule. The last time I did a presentation on this topic was 2 years ago during one of the information sessions held by the commission. So it's been a little while since I've talked about it, so it's a little bit more than an update, but I promise you I can talk fast. Okay. So the home and community-based settings rule was issued by the Centers for Medicare and Medicaid Services, which is CMS, the federal Medicaid agency. It applies to settings, and a setting means the location where home and community-based waiver services are delivered. So for DDSN, think like a day program or a residential setting. It became effective, the rule became effective in March of 2014. There was a multi-year transition period for states to come into compliance with the requirements of the rule. Initially, the transition period was 5 years. Under the Trump administration, 3 additional years was added, and COVID added 1 more. So now we're at a 9-year implementation period, but compliance supposedly is going to be required by March 17th of 2023. A little bit about the rule just in general. The purpose of the rule is to maximize opportunities for participants, waiver participants, to receive services in settings that are integrated into the greater community. So not isolated from, but integrated in the community, to realize benefits of community living, including opportunities to seek employment, work in competitive integrative settings. And the focus of the rule is really on the experiences of the people receiving those services and the quality of those experiences. This rule includes certain key provisions, one of which is the characteristics of the settings. So the settings, again, are where waiver services are delivered, and any or all settings where waiver services are delivered must have these characteristics. There are 5 of them. They're a little bit lengthy. I'm going to read them. Be integrated in and support full access to the greater community, including opportunities to seek employment and work in competitive settings, engage in community life, control personal resources, and receive services in the community. The second one is to be selected by the individual from among setting options, which includes non-disability specific settings. Third is to ensure that an individual's rights of privacy, dignity and respect, and freedom from coercion and restraint. Fourth is to optimize autonomy and independence in making life choices, including but not limited to daily activity, physical environment, and with whom to interact. And the last one is to facilitate choice regarding services and supports and who provides them. So those are the 5 characteristics that waiver settings are required to have. Another key provision of the rule is the application of some additional conditions. And those additional conditions are applicable when the setting is a provider-owned or controlled residential setting. So you may remember that in our home and community-based waivers, there's a service that's called residential habilitation, and that service is defined as care, supervision, and skills training. That service does not include room and board, right? So what the settings regulation is saying is that when the setting in which the person gets residential habilitation is provider-owned or controlled, meaning the person who lives there, the person that owns the setting is the provider. So my landlord and my residential provider are the same entity. That is a provider-owned or controlled residential setting. So if my landlord is some management group and my residential provider is ABC DSN board, these are not applicable. Okay, these are not applicable to day programs. They are applicable to residential settings. There are also 5 of those additional conditions. Those are, first of all, the unit that the person has is a specific place that's rented, owned, or occupied under a legally enforceable agreement. So basically, if you're living in the provider-owned setting, you have a lease. Just like if you're renting an apartment or a house, you have a lease. The person has a lease. Secondly, the individual has privacy in that unit. So in the unit that they are leasing, they have privacy, which includes lockable doors with only appropriate staff having a key, choice of roommate, freedom to furnish and decorate within the lease agreement. The third one is that the individual has freedom and support to control their own schedule and activities, including access to food at all times. The individual can have visitors at any time is the fourth one. And lastly, the setting is physically accessible. So those first 4 that I mentioned, having a lease, privacy, controlling your own schedule, and having visitors. If you're looking at the presentation in your binder, you'll see a little M by those, and that is there just to say that those additional conditions can be modified based on the needs of the person. So it's not appropriate for maybe everybody to have access to food at all time. Some people perhaps can't handle that. But if you're in a provider-owned or controlled setting and you live, say it's me, and I live with 3 other people, and I can't really handle, I haven't learned to appropriately control access to food at all times. So my ability to do that may need to be modified. One of the points of this rule is that that's fine. If I need it, I can modify it. But that solution cannot take away my roommate's ability to have access to food at all time, right? So if I can't have access to food at all time, maybe a simple solution is to lock the kitchen. But if everybody else in the house who also lives in this setting can't have access to that kitchen, there's a problem, okay? So on an individual basis, and then when it's modified, people have to be taught to be able to hopefully achieve the ability to control their own food in this case, okay? So some things are modifiable, some things are not. Physical accessibility to the setting is not, that's ADA, you can't really modify that. So another key provision of the rule is the identification or the defining of the settings that are presumed to have the qualities of an institution. So you know that home and community-based services waivers exist so that people can get the needed Medicaid services in their home or community instead of an institution. That's the whole point of them. And for many years prior to waivers, the only way to get the services that people needed was to be in an institution. So the waiver is waiving that institutional requirement. We talked about the purpose of the rule being able to maximize community living for people. And this key provision is there to make sure that settings are indeed doing that. And they are maximizing opportunities for community living, and they are not operating or acting like institutions. So this part of the rule is to make sure that the settings where waiver services are delivered don't act like or operate like institutions. They may not be licensed that way, but you can certainly run one that way, okay? So the setting or rule, they identify the kinds of settings that are presumed to have institutional qualities, or those settings that act like or operate like an institution. And those are settings that are in or in a public or privately owned facility that provides inpatient treatment. That simply means perhaps you have a residential setting on a wing of a hospital, or you are operating a day program on a wing of a hospital. settings that are on the grounds of or immediately adjacent to a public institution. So a public institution, think about a DDSN operated regional center or a DSN board operated ICF IID. The third one is settings that have the effect of isolating individuals receiving Medicaid from the broader community of those not receiving Medicaid services. So having the effect of isolating is a little bit more general, more subjective than the other two kinds of settings that are presumed to have institutional quality. So the state had to figure out what it meant when settings had the effect of isolating, and so they did. And for South Carolina, settings that may have the effect of isolating are defined as a community residential care facility, a CRCF, that was formerly an ICF and is physically located to another CRCF that was formerly an ICF. I know that sounds like a lot. So basically, one day there were two ICFs sitting next to each other, and they were providing institutional ICF services. The next day, the license of those settings changed from an ICF to a CRCF. So the question becomes whether or not what happens within the walls of that facility changed, or are they still operating like two ICFs, or are they now operating like two home and community-based waiver settings? The second one is a disability-specific apartment complex. A disability-specific apartment complex, they are talking about setting where only DDSN eligible people reside. So it's not like your neighbor is someone who decided to rent an apartment in this complex. It is only people with disabilities who live there. A setting that is surrounded by a fence with a locked gate. Fence with a locked gate was chosen basically because locked fences serve two purposes. They keep people in or they keep people out. So there's the reason for the fence is important. And they're presumed to have the effect of isolating because they may, if they're locking people in. If you're locked in and you have a key to get out, you're not locked in, okay? So again, if you're surrounded by a fence with a locked gate, you could have the effect of isolating. 3 or more home and community-based waiver settings clustered together and operated by the same provider. So with this, they're talking about a campus-like setting where a lot of people say, what's wrong with that? Generally nothing, maybe nothing, unless it's truly acting like a campus. If everything that you do is within that cluster of that setting and it's campus-like, it may act like an institution. Regional centers are campuses, colleges are campuses. So sometimes the campuses can be a problem and sometimes it's just a couple of houses located near each other. So to achieve compliance with the settings regulation or the settings rule, states needed to assure that all of the settings had the required characteristics that we just discussed. We had to ensure that the provider owned and controlled settings met the additional conditions that we just discussed. The state needed to identify any existing settings that were presumed to have the qualities of an institution, and they're expected to stop creating or allowing settings to come online that have those qualities. State needed to take a look at the existing settings to determine if they indeed overcame the presumption. So again, it was settings that were presumed to have those qualities, so the state needed to decide whether that presumption was correct or incorrect. And then the last thing is to provide information about the settings to CMS. So if there's an existing setting that's presumed to have institutional qualities and the state took a closer look, then the state needs to provide information to CMS. So there have been a lot of activities that have happened since 2014 to implement this regulation. I've kind of listed those, very high level discussion. HHS looked at the code of laws, DDSN standards, those kinds of things. They did a review of adult day healthcare settings, which are settings where waiver services are delivered that are not DDSN operated settings. Public consulting group was hired by DHHS, and they did a review of all of the DDSN settings. And there were 1,321 of those. We provided providers with the results. We had them create an agency-wide compliance action plan to show that they had adjusted their policies and procedures to be in compliance with the requirements of the regulation. And then the state identified the settings of the 1,321 that were presumed to have the qualities of an institution, and we took a closer look. Okay, so I think it's maybe slide 11. There's a table and it says, it shows what the results of the 1,321 were. If these look a little different, or if you've looked back, or if you know anything about the settings regulation, the number of 114 is different. This seemed to fluctuate through the years. Maybe we thought 3 were clustered together and they really weren't, or maybe we thought that a setting was a provider-owned and controlled setting and it really wasn't. So the 114, I'm pretty sure is final, so that's where we are. CMS, when they talk about the rule, they assign a category to the settings. So you'll see in the first column that there's a category 1, 2, or 3. We had no category 1 settings, so we don't have any that are on the wing of an inpatient treatment facility. We did have 7 settings that were on the grounds of or adjacent to a public institution. So 4 providers were operating in 7 settings. They were sitting next to an ICF IID operated by that provider. And there were 107 settings that were presumed to have the effect of isolating, operated by 22 providers. So the state did take a closer look, or decided the state had to take a closer look at those 114 settings, and a process for that closer look was created. It was called state level review. So for the state level review, we requested that the providers who operated one of those 114 settings send to us evidence to support that they overcame that presumption, and then we put an evidence package together. So an evidence package was the information from the provider and then information that DDSN had collected. For providers, they were told basically to paint a picture. Paint a picture of how you're not like an institution. What is it that defines the fact that you've overcome this presumption? You might be sitting next to an ICF, but you're not operating like it. You might have 3 or more settings clustered together, but they're not operating like it. There's some examples of some information that providers were asked to include, and those are listed. But basically, they were asked to paint that picture. Tell us what you're doing. How are people supported to be in the community, engaged in the life of the community, and show how they could overcome those settings, that presumption, sorry. So for the DDSN information, we added the provider's compliance action plan. So that overall plan for that provider, we added contract compliance review results from DDSN's QIO, licensing review results, and then if it was a residential setting, we added residential observations that were completed by the QIO, and if it was a day program, then we added those settings as well. So that the provider information and the DDSN information together became the evidence package. There's one thing to note about the evidence, and this is directly from CMS. CMS specifically said that any evidence to support that a setting has overcome the presumption may not include information that focuses on the aspects or severity of the disabilities of the people served. So in essence, they were saying it's not okay to say, but the people in this home can't, therefore we can't. So CMS is basically saying that is not good enough. It is, if it's a home and community-based setting, the people are supported to be in their home and in their community. And just because their disability may be more severe than someone else's, it is not sufficient. So providers would have to work around that. So the state decided to create a state-level review team to review these 114 evidence packages. It was a 5-member team comprised of 3 DHHS staff and 2 DDSN staff. There was a stakeholder advisory committee that was impaneled in case there was disagreement among the state-level review team. Each member reviewed every evidence package individually, and then the team came together to discuss the package and reach a decision. When I mentioned earlier that CMS identifies settings as by category 1, 2, or 3, the the decisions that the state could reach regarding a setting depended on the category the setting was in. So those that are on the grounds of or adjacent to an ICF, the team could have said they overcame the presumption or that they didn't overcome the presumption, and that would affect what happened afterwards. For Category 3 settings, the decisions were a little bit different. They could decide that they overcame the presumption and they were fully compliant by July 1st of 2021. If that was the case, that provider and that setting was considered compliant and everything was complete. The second decision they could reach for the Category 3 settings was that they were not fully compliant by January 1st, by July 1st, but they could be compliant. So those settings that were not yet compliant, if they were not yet compliant, information about those settings will be submitted to CMS and they will be subject to review by CMS. And then the last one is that they didn't overcome the presumption. So the results are listed on what may be slide 21. We had 7 settings that were on the grounds of or adjacent to, and all of those settings, 7 settings did overcome the presumption and were determined to be compliant. Of the 107 Category 3 settings, there were 84 that were determined compliant by July 1st, 2021. There were 23 settings that were determined not yet compliant. So they have some more work to do. So in terms of next steps for the Category 2 settings, the next steps, we are essentially at a point where we are waiting on CMS to select a sample from those 7 settings, and they will do their review, and we'll figure out where we go from there. And then for the Category 3 settings, there are 84 settings where there are no additional actions needed. Those providers are done. They're considered compliant. There's nothing else to do. For the 23 settings not yet compliant, information about those settings will be shared with CMS and they will be sampled. So a sample of those 23 settings will be selected by CMS and they will do a review. But you need to remember with the 23 settings is that we've said the team decided they're not yet compliant. They think they can be by March of 2023, but they're not yet compliant. So HHS has reached out to DDSN and basically asked that specific actions be taken regarding those 23 settings. So again, if they are not compliant by March of 2023, Medicaid services, Medicaid waiver dollars can no longer be spent in that setting. So they would be removed as Medicaid providers. So prior to March of 2023, a decision really needs to be made that yes, indeed, they are compliant. Because if they are not, then the people who live there need to know. And something would have to be done in terms of where they go and what happens to the services, since they cannot use their Medicaid waiver to cover where they are living. So something has to be done before that. So DHHS has asked DDSN to create a dedicated team to provide technical assistance and monitor the compliance. They're asking that DDSN require each of the 5 providers operating those 23 settings to develop a compliance transition plan that details the actions to be taken to ensure compliance. Those will be submitted to DDSN by October 1st, and then require each provider to submit to DDSN a quarterly report throughout the process. So between now and when they reach compliance to submit quarterly reports detailing what they've done to achieve compliance. DDSN is to report to HHS by May 2022 the results of all of our monitoring and actions thus far. DDSN is to require from each provider no later than November 1st, 2022, a new evidence package. So again, the same sorts of evidence that we reviewed this last time, but new information that will hopefully demonstrate compliance with the settings rule. And then the state level review team will review those again. So all of this information that I just shared with you is detailed in the statewide transition plan that the Department of Human Services has posted on their website, and is also posted on the DDSN website now. So you can certainly go in there and look at it. Actually, the statewide transition plan is open for public comment until October 1st, between August 23rd and October 1st of 2021. And there are some webinars to discuss the changes to the statewide transition plan. There's a link included if you're interested in it to where you can get to the statewide transition plan. So sorry it took a little bit longer than I had hoped. Do you have any questions?
I do have one question and or comment, I guess it was a question. And in the interest of time, I'm only going to ask one, although I could have asked several based on what you were saying. So we do have to move on, so I'm not going to take long. But in one of your 5 key provisions, it says that the individuals can have visitors at any time. I just think they need to reevaluate how that would parse with security for the other individuals. If somebody has a not so nice visitor that could affect the other people in the place. I just think they need to, somebody needs to reevaluate that.
So again, that is a federal requirement. You can modify the requirement, meaning based on the needs of the person. So if I am someone who makes very poor decisions about who comes into the house. The other thing is that there are courtesies that you extend when you live with other people. So if I have an apartment on my own, and that is my waiver setting, my residential setting, who I have in my apartment is my business until it reaches the level of, health and safety.
Some people
versus when you live in a house with 3 other people, and then there are courtesies that need to be extended. So we have encouraged providers to work on house rules or house agreements, which means that the people who live there come together and say, I don't want visitors after 10. I don't want anybody spending the night unless I know who they are. I don't want anybody spending the night in my house at all, whatever. But those are courtesies that as roommates, they discuss and they decide. And that's how we've been able to mitigate it thus far.
Very good.
I do have a question. On the 23 that are non-compliant, are any of those DDSN-owned facilities?
No.
Are they providers? Are they?
They're provider operated. I am not sure. I don't think they're DDSN owned. I think that DDSN has long.
I just want to make sure, because I know we have some legacy homes and.
I am not sure if they're any of the legacy homes or not, to be honest with you. I know that at least 4 of them are very old settings, probably constructed by DDSN 100 years ago.
Now, we have a list of who those are, those 23 that are not compliant. Will we get a list of where they are, or how does that work?
Okay, so because these are people's homes, and there's a limit to the public information that is in the statewide transition plan.
Okay.
So in the statewide transition plan, when you look at it, you will see a name of a home. So let's say the name of the home is Apple. So it will say the Apple setting, and it will say the region of the state in which it is. Okay. So you know that the name of the setting, the public can see the name of the setting and the region. But it's not so specific to say the Apple home operated by blank DSN board, because usually the name of the setting is the street on which they're located.
Okay.
So there's some effort to maintain the privacy of the people who live there.
Okay.
Of course, if, DDSN absolutely does have that information.
Okay. Good. All right. I guess we need a motion. Correct?
No, ma'am, I think this is just for information.
Yes, I'm sorry, I didn't see Commissioner Bell.
Just to follow up, for the 23 settings that were determined to be not in compliance, were we seeing a consistent characteristic across that, or was it just widely varied all over the place?
It was varied among the settings. So there were some similarities if the provider operated in multiple settings, right? So you would expect there to be some similarities across that provider settings, but from provider to provider, not really, no.
So the consistency was sort of within the providers as opposed to a system. We don't have a systemic, all 23 showed this characteristic method. Okay.
Absolutely.
Thank you.
Actually, we do. I think this is DHHS has outlined specific actions to be taken by DDSN regarding the 23 settings not yet compliant. So do we need to move forward to just, and it says we have to do all this stuff. Do we need to send that forward, or how does that work? Do y'all just do it, or?
Well, we need to, it wouldn't hurt for us to make a motion there to do it by the date on there instead of, and so that we do not, we're not, so that the commission is not granting an extension.
Okay.
Which we don't want to do.
Let's move forward and do that, and that'll give y'all the authority to go ahead and set this stuff up, I think. Okay. If y'all don't mind. Can I have a commissioner make a motion?
I would have a motion that they would be compliant by the date in our presentation.
Okay. All right, do I have a second on the motion?
Second.
All right, I have a motion and a second on the floor. Any discussion regarding the motion?
No, except to say that, Christie, would you put the date, because I don't know the date offhand, but would you put it in the minutes, please? Thank you.
March 17th, 2023.
Thank you. Sorry.
And I think I think it's good. I think we've got to give these folks, these 23 homes, a deadline and say, the commission is serious about this. We intend to fall in compliance with that. So let's move forward. All in favor, please signify by saying aye.
Aye.
All opposed, nay. Hearing none, the ayes carry, and you have the authority to move forward with this.
Thank you.
Sure. All right, our next item on the agenda is the quarterly incident management report. Miss Ann Dalton will be giving that to us.
Greetings from the quality and risk management areas at DDSN. As you guys know, we are a small unit within DDSN, and we are typically associated with communication about opportunities for improvement. I think some might describe that activity in slightly different terms, but we do try to be collaborative and constructive in our feedback that we are offering. Our system is based on a cycle of continuous quality improvement. Within that vein, we have a dedicated staff person who is responsible for reviewing about 15 allegations of abuse, neglect, or exploitation, around 25 critical incidents, and a varying amount of death reports each week. And of course, that includes a lot of associated documentation that supports the reports that are submitted to our office. So there's a lot of going back and forth, and we want our process to focus on timely reporting, the initial reaction to ensure that the person is safe and free from harm. We want a systemic response to ensure that other factors that are identified within the review process are appropriately addressed. And of course, we want to prevent future occurrences. It's important to remember in this process that the various incidents that are reported to us are self-reports. So at DDSN Central Office, we do not have a mechanism to identify instances of abuse which are going on out and among our community providers or our regional centers. So those instances are self-reported. And as the reports come in, our staff work with the provider staff to make sure that they are telling the whole story. We want the reports to stand alone each time. There is a provider attestation that the reports must be valid, complete, and correct. So again, it's a continuous process to work with folks. I'm sorry, I do not know exactly which tab. I'm assuming it's possibly tab 8 in your folder, since unit was 7. Okay. So as you take a look at the information in tab 8, it is once again divided out for community residential day services and then our regional centers. When you take a look at the community residential information in the day services, you'll see that the trends are pretty much following what we had expected for fiscal year 21. They are slightly lower compared to fiscal year 20, but COVID pretty much threw everyone for a loop. So there are going to be some inconsistencies here and there, but there wasn't really anything alarming. We're well within our 5-year averages for that. The administrative review findings are lower. Those are reports that or investigations that are completed by the State Long-Term Care Ombudsman Program or through DSS. And typically those reports run a couple of months after the allegations are submitted to us. So we will be catching up on those administrative review numbers over the next few months, and you will see those numbers increase, according to their findings. So the report really shows a significant change in the trends when you start looking at the regional centers. As I mentioned earlier, we have a system in place that's based on self-reporting. Due to an incident that occurred in early May, we felt that it was evident that we needed to take a closer look at one of the reports that was submitted, and we sought the video to correspond with the written report. That led to 2 staff here at Central Office being assigned to review video and look at written reports that were submitted for other instances. And that has led to a number of other reports in our system. So you'll see that there is a spike there for the 4th quarter. For fiscal year 21, we have a total of 181 A&E allegations across all of our regional centers. 83 of these reports were for the 4th quarter. So if you might remember that when I was here in May presenting this report, I talked about the fact that the number of reports was low for the fiscal year, especially given the concerns we were hearing about staffing and other issues related to COVID. So we more than caught up in that 4th quarter. Of the 83 reports that we have for the 4th quarter, 49 are attributed to one of our regional centers. And at this point, as reported in the media, we have had 11 arrests for staff who are formerly employed by regional centers. 9 of these arrests have been recent and relate to 13 individual charges or warrants. So we know that there are about 15 reports out there that are currently under investigation, either with SLED or the State Long-Term Care Ombudsman Program, and we are awaiting the results of those investigations. On the next page of your tab 8 information, you will see the critical incident information and our fatality reporting. Our critical incident numbers have been adjusted to exclude the reports for COVID positive individuals because that's a whole slew of other reports that we have coming in through our system. The reports, the remaining reports emphasize, a continuing need to address behavioral support issues throughout our system. Our reports that are related to law enforcement calls, suicidal ideations, or restraints continue to trend higher than what we might like to see. And then for our fatality reports, our numbers in both the community and the regional centers far exceed what we have experienced in our 5-year averages. COVID-related fatalities are certainly a factor. We also have a lot of general respiratory and cardiac-related issues that have affected the folks that we serve. And the vast majority of the fatalities have occurred in individuals over age 60 with other comorbidities. We talk a lot about folks who are aging in place within the residential setting. So the majority of the fatalities that have been reported have been in folks who are over 60, and many have terminal conditions at that point. So you have the data in front of you to correspond with what I have shared with you in this report. As always, we are happy to provide additional information, to answer any questions, and if there's ever any additional information that you would like for me to include in these quarterly reports, I am happy to do so.
Thank you. And do you have anybody have questions? I have a question. Can you kind of tell us, I've gotten a lot of calls about why it takes so long. Why it takes so long from the time an incident is reported till the people are arrested or action is taken. Can you kind of go through that process for this commission so that they'll be able to explain it to people in the community as to how that goes about? Where does the report come from? Who writes the reports to the rest? Kind of go through that process.
Sure. Okay. So when there is an allegation, we expect the person who witnessed the event, or the person who hears about the event, whichever the case may be, to make that report to the state the state law enforcement division. For anyone who is receiving services in a residential setting, that report must go to SLED. There is an intake number that they call to make that report. SLED will then make the determination for how that particular case is vetted. So if the allegation appears to have a criminal element, they will vet that allegation to local law enforcement if it's one of our community providers. If it is for one of our regional centers, they will retain that report and they will do the investigations through their vulnerable adult investigations unit. If the allegations appear to be a standard of care or non-criminal in nature, then SLED will vet that allegation to the state long-term care ombudsman for residential settings or to DSS Adult Protective Services for an event that occurred out in the community. Often, if the details that are reported to SLED are incomplete or do not present a situation that would require outside investigation, they may take that report for information only. So, how the cases are vetted follows a particular flow chart. What happens after that gets a little complicated because if the reports go to the ombudsman or to DSS, or if SLED decides to take the report for information only, the provider is permitted to do an administrative review, an internal review where they're looking at the who, what, when, where, and how of the incident, and they are able to make a determination about any misconduct, rules or policy violations, or systemic issues that they need to address. At that point, the provider is able to make a determination about personnel actions that may need to take place. And one of the things that we really stress with our reports is that the personnel actions don't end your report. Your corrective actions or your management action doesn't end with the personnel action. There's still so much more you need to look at in terms of why that allegation occurred. Whether it's a false allegation or whatever, it still needs to be addressed. So the agency can bring the person back to work. Sometimes there's no need for any retraining or disciplinary action, or they may decide it's a good employee who made a bad decision. We're going to provide additional training, additional supervision, support, whatever. There may need to be additional training in particular policies. Maybe a policy needs to be revised. Maybe the behavior support plan needs to be addressed. There are all these other factors that are considered. But as long as the allegation was not criminal in nature, the provider has the flexibility to take pretty quick action, and there's not the lengthy waiting period. Now, if the allegations are criminal in nature, then we are dependent on the law enforcement system to take its course. Law enforcement entities have many competing priorities, so what may appear insignificant to other people, very significant to the person who might have been a victim, it may not rate as high on the law enforcement to-do list in terms of getting out there for that investigation. So often there is a delay, but because SLED determined that the allegation had a potentially criminal element, we are dependent on law enforcement making that decision. And our policy says that people will remain on administrative leave without pay while law enforcement is completing the investigation. And sometimes in rural communities, the investigations are completed very quickly. Sometimes they surprise us and they get stretched out much longer than more urban communities where they may actually have an investigator that is assigned to special populations, and that definition can certainly vary. But some of the larger, Columbia, Greenville, Charleston, Florence, they have an investigator that may have additional training to help them with investigations that are not your typical run-of-the-mill kinds of things for law enforcement.
Okay. Let me ask a question. When an incident occurs, you get a report, any kind of incident, y'all get a report here at DDSN from from the administrator at the ICF, correct?
Yes, these are self-reported incidents. So they make a determination based on policy. Is it a critical incident or is it an allegation of abuse, neglect, or exploitation? And sometimes there is a fine line if it is an injury of unknown origin. If someone has bumps and bruises,
Yeah.
and they cannot explain how that occurred, it should be reported as an injury of unknown origin.
Okay. And in that case, we obviously have video and that kind of thing in our facilities. Do we immediately go and pull the tapes on those incidences as they come in and preserve those tapes?
That is a very complicated answer. So up to this point, video has been reviewed on a case-by-case basis at the centers. It has only been within the last 6 to 8 weeks that staff here at central office and 2 staff have been permitted to review video at one center.
Okay.
So no one is here is looking at video from any other center. The staff at the centers, and Rufus, please correct me if I'm wrong, but the staff at the centers are reviewing instances that are reported, but I do not believe, based on staff resources, I do not believe anyone is consistently reviewing video on a random or scheduled basis.
So we aren't preserving, what I'm asking is, when a report comes in to DDSN saying there's an incident, we aren't going back and grabbing that tape and holding it of that incident. If it's in a position, if it's in a place where it can be.
The video is retained for 60 days.
Okay.
And unless,
are we getting all these incidents within, are we getting to these incidents within 60 days is my question, I think.
Personally, I do not believe that we are getting to all of them. And that is based on the fact that right now we are looking at incidents that have been reported and comparing the written report to video, and we're finding some inconsistencies. Every day, that 60-day calendar is rolling forward. So if we feel like there might be something we need to look at with the staff at an earlier date, it's gone.
That's what I need to know. Any other questions from the commissioners? Thank you, Ann. We appreciate it. All right. What time is it? Okay, we've got, remember we do have, somebody to remind me we have to do a hard stop. All right, next item on the agenda is Pat for fee for service update. And I think Pat's got the next item after that is cost report update.
Good morning. The last remaining hurdle to get the fee for service is for the Idrt waiver renewal to add individual residential settings and individual rates. I want to thank Department of Health and Human Services Director Kerr and his staff for, in early June, they made a change of course to accommodate our needs, and they have worked tirelessly for the last 2.5 months to get us where we are. I have not received the official word that it is in the waiver. I'm optimistic, and as I am the third person to report today, there is an announcement on the Idrt waiver renewal for public notice starting on August 25th, and in there it makes reference to adding residential tiers, which is a clue that things are still positive. So I'm optimistic. Once we cross that threshold, January 1st, 22nd will not only be our target date, it has to be our target date because that will be the Idrt waiver renewal going into being executed. Between now and then, I believe it's a lot easier lift than the BNI conversion, less transactions. I think we have better systems to support it. We will have to address the cash flow issue for providers because on January 1st, when we did the BNI switch, it was about 24% of their revenue that they had to cash flow for 30 days. And now it's going to be the remaining 76% of revenue. So it's going to be a much, much bigger cash flow issue. Many of our providers can handle it. Some will need help. So we'll have to come up with a safety net program to help those accommodate that cash flow 1 month delay, going from beginning of the month to end of the month. There'll be some other kind of idiosyncratic things to work out between now and then. Rufus's team had done a really good job on addressing the state-funded residential individuals in our system who we were paying state funds for. They've converted probably 30 or 40 of them, representing $2 or $3 million. We still have, my estimation, 30, 35 that are state-funded that probably are not Medicaid eligible because of financial reasons. So as we go to fee-for-service, the capitated system has kind of masked these individuals. We will have to address them in a safety net fashion, but we will have to address that group. So other than that, I'm optimistic, and that's the direction we're going. Any questions on fee-for-service?
Anything? All right, let's go to the cost report.
Cost reports, it ties directly with fee-for-service. Ever since the movement to get the residential settings into the IDRD waiver renewal, the foundation of probably the key element to the rate increases is having our fiscal year 19 cost report completed and accepted. And so we've been doing double time on that for the last 2 months. It has taken some revisions, but it is prominently in the draft report that I saw as the lever for increasing rates. And as we talked about in the finance meeting, there was substantial excess cost in our system that will be factored into rate increases. 13, 14, and 15. 13, 14 are complete on my desk. They do need adjustments that we made to the 19 cost report. They should make them by early September, and then I can sign them. The staff downstairs has done a great job with 19, but they were all brand new and it was a learning curve. And so they'll take their lessons from 19. We'll adjust 13 and 14 and 15. Have them done in September.
Okay. What about this past year's cost report? Is it finished?
We have fiscal year 20 cost reports. Right now, the remaining cost reports would be 18 and 20 and 21. We have to get 18 done next because HHS wants to kind of wrap up 13 to 18 because of there was a way they funded. They wanted to wrap all that up, and then we would do 20 and 21. I mean, they're both important. They're both critical for seeing if there are any liabilities, but using 19 for the IDRD waiver renewal that will carry us for multiple years as far as having the rates supported with a cost report. And I'm hoping that after probably this time next year, we get on a rhythm of having reports in by November 1st and having a cost report by February 1st.
All right, so we're anticipating by then being caught up. By November of next year, being completely caught up. Sorry.
I would hope February 1st of the following year would be ready. Yeah, I think it'd be ready on time.
Gotcha. Yes. Okay, good.
Right.
All right.
Any further? 13, 14, and 15 is one we just said we were going to have done by the end of September.
Yes, yeah.
Right. And then we moved to 18, and then 19, 20, 21 by next year.
19 is done. 19 is done.
Okay, 18, 20, and 21.
Yes.
By next year this time. Be updated. Very good.
February.
Huh?
February.
That's right.
Yeah, not this time. We got a few.
We're getting there. We're getting there. That's good. We're catching up. That's,
all right. Thank you.
That's good news. Thank you. All right, Mr. McBurney, time for a COVID-19 update.
Yes, ma'am, and I've been told that I'm on the clock here.
We've got about 15 minutes. We have to go to a hard stop.
Okay. That's more than I was thinking. I don't think it'll take that long. COVID-19. I think as you've all seen, I don't need to rehash what you've seen in the media, in the news reports. We are experiencing a spike of COVID-19 due to the Delta variant of COVID-19 primarily. DHEC is seeing numbers on a daily basis of 2,000 to 3,000 a day. Some days we go over 3,000 and some we hit 4,000. But it's roughly been in the 2,000 to 3,000 range for the last 4 weeks. And like I said, the primary reason for that is the Delta variant. DHEC, in a webinar yesterday, Dr. Kelly said that these are numbers they had not seen since January. I think that if you've heard anecdotal evidence, emergency rooms are full and hospitals are under some stress. This spike is real in the state as a whole. Almost every one of our counties is in the high category for COVID numbers. In our network, we have seen a rise in positivity rates over the last week or over the last 4 weeks. The last 4 weeks, consumers in our network, these are in the community, we've had 57 positive cases and 105 staff positive cases. In our regional centers, we've had 1 consumer who tested positive over the last 4 weeks, and about 20 staff who've tested positive. Now, we did have 1 positive consumer at one of the DDSN operated autism homes test positive yesterday. And our regional centers right now, due to staff contact, have tests out. We got there are 100 tests out right now. We got a big slew of them in last night from Coastal Center. They were all negative. So that's good news. When you look at the numbers in our network, based versus the rest of the state as a whole, you'll see that we are low. Between the rest of the state, while we've gone up, our numbers are low. And the one thing we can attribute that to is vaccination. Vaccination works. In the community, our consumers are vaccinated at a rate in the high 80s, as an average in the high 80s, and the staff are vaccinated at around 40% in the communities. At the regional centers, we're right at about 90% for consumers being vaccinated, and we are at roughly about just shy of 55% at the regional centers for staff. Now, as you'll notice, that's an increase from what we.
The regional centers, that includes the ICFs as well, or?
Community ICFs are part of the community number.
Okay.
These are just the 5 regional centers. Okay. The reasons for when I say I'm happy when I see that 55%, because the last report we gave you was between 35 and 40 for staff at the regional centers. So some work has been done at the regional centers to get vaccinations. The bonus has helped, but one of the real keys that has been is that we all at every one of the regional centers we have vaccine on board right now. We have vaccine on campus, and that has made a difference as far as being able to reach out to kind of communicate individually with folks one at a time and get them vaccinated. I want to thank our guinea pig for that project, the first one who got vaccine on board at the regional centers and kind of developed the plan. Tom McDaniel and his infection control nurse, Cindy Huff, did a fantastic job of getting that plan going, and really, I know 55% may not sound, we'd like it to be at 75 or 80%, but when you think about it, 55% is ahead of the state. The state is vaccinated at 47% right now, as of the day ago on the DHEC. So we're ahead of the state for our staff vaccination, so that is good. Going forward, what are we doing? We had an infection control meeting last week and have re-emphasized to the regional centers the infection control guidelines that we put in place. DHEC has helped us tremendously with developing our infection control plan. It has worked tremendously during COVID. Our regional centers have done a fantastic job of controlling COVID and keeping it contained. And part of that, you know, a large part of that is them following our infection control plan that was helped, you know, Rufus and I reached out and we got a lot of help from DHEC, a lot of help from Rebecca Walker at DHEC, and a lot of help, you know, and from Dr. Traxler at DHEC. She was helpful in getting our infection control plan going, and it was very helpful. We have ionization filters in all the air units at the regional centers. HEPA filters, HEPA units into portable HEPA units that can be moved around. And then we have backpack sprayers to spray down areas at the regional centers. All those are being employed right now. For as far as putting out information, we're continuing with our situation report. I think we're going to put out our 50th COVID-19 situation report this week and or next week, and we will continue to push out information on COVID, on infection control from DHEC, from the CDC, from the World Health Organization, all these things, all things that can help with infection control, with education, information, training.
Does that go out to all of our employees? Is that correct?
It goes out to all the regional centers and the entire network and all of the providers.
Okay, good.
Yesterday, we had a very successful webinar with Dr. Jane Kelly from DHEC. She's the assistant state epidemiologist, and she gave us an hour and a half of her time, along with Rebecca Walker from the infectious disease unit at DHEC and Hannah Rugner. They have been fantastic for us. They did a fantastic webinar yesterday, updating us on the Delta variant, what's new, what's different, and what infection control measures are effective going forward. And I want to thank them for their help. It was very successful. We had over 320 people logged on. That's 320 logins. There was probably more. It's probably about 500 folks, gathered in conference rooms and things like that. So our network received it well, and I'm still getting emails all morning asking for the slide deck, and we'll be sending that out this afternoon to everybody. The last thing we're doing Tuesday, we're going to reconstitute our weekly COVID-19 briefing here at DDSN. That is a quick 15-minute every Tuesday morning to give an update on the numbers and to push out information. Rebecca Walker sits in on that. Dr. Robin Welsh, our medical, our chief medical officer, she sits in on that and pushes out information from that she gets through Prisma and things like that to our network. So it's very helpful. It's a 15-minute digest of information. We get questions and concerns answered, and it has been very effective as far as coordinating response to COVID-19. So, pending any questions, that's my report.
Yes, sir.
You mentioned that the bonuses has helped. So are you saying to us to keep that on the radar?
Oh yes. Oh yes.
That's a good oh yes.
Oh yes. That is helpful. It's a tool that you can use to the way Tommy McDaniel started it with Cindy Huff is they would have clinics, and they would have and then they would individually, hey, come on, get your bonus, come on, get a shot, get your bonus, that type of thing. They push out information. DHEC was very they were thrilled when they heard our percentage for staff.
Well, I want to thank all of our staff that have taken the opportunity to go get vaccinated, and just encourage those that are listening to please go get their vaccination. If you're a DDSN employee, we do offer our bonuses at Tell me what it is.
$100.
$100.
So we don't take that off the table.
For fully vaccinated folks, it's $100.
It's $50 per shot.
$50 a shot, or if you get the
You get
one
a single
shot.
shot.
Yeah, if you get the one shot, $100.
We want to make sure our
Rufus took
consumers
his
are
mask
safe.
off on that.
And while, while this isn't 100% proven, it is proven that even if you get it, it lessens the
Absolutely.
effects. Am I
Absolutely.
correct? And so we just want to encourage our staff and our employees and our consumers to take the vaccine,
Right,
please.
the way the vaccine works is it doesn't make you bulletproof.
That's right.
What it does is if you get infected, it's what way it's been described to me by doctors is it winds up being cold-like kind of a bronchial infection type of thing rather than something that debilitates you.
Well, I know I've had mine and I don't feel completely safe, but I do feel better about it.
And that was Dr. Kelly's message yesterday. She went through the science of why vaccination works and walked us through the numbers and it is there's a lot of back and forth going around out in the you hear it out in the news media and everything, but vaccination, the numbers show that vaccination works, and we encourage everybody to get vaccinated.
Please, we encourage our staff and especially our employees to take the opportunity to go get the vaccination. And any of our regional centers have them available for you.
That's exactly right. They're on campus at every one of the regional centers right now.
Any other questions? Gary?
How are we suited for PPE across the network right now? Any issues that we're having? I know early on that was a big problem.
I can tell you the regional centers were full. We're over full a little bit now because we got a donation. ProPac down in Charleston that works with the Charleston Disabilities Board. They donated some PPE for us, and we were happy to get that. And so every one of the regional centers took advantage of that and got on board. We actually took on a little bit of ourselves that I stored over at Midlands that we're going to be distributing out to the community. That's something that we're going to start next week, making it through EIs and case managers. We're going to make PPE available.
And are we having any issues with compliance with our PPE requirements in the centers in particular? I mean, we haven't really.
That is always it's always a battle, and that's part of this Tuesday morning information share that we do. We pump everybody up, get out there and make sure everybody's not letting the mask fall down on their face. Not letting it hang off the side, have the mask on, that type of thing. And employ the PPE where you need it, when you need it, and wear it properly. We've just gone through every one of the regional centers as part of the OSHA emergency temporary standard that they put out in June. We've just done kind of a mini fit test program so we've just completed that. At all the regional centers for the N95, so we're ready when and if we need to employ those measures. We're ready.
Okay. Any other questions? All right, hearing none. Thank you so much. I think we had a hard stop scheduled for 12:15.
Yes.
We're going to take that hard stop. I think we're 2 seconds early, but that's okay. We're going to take the hard stop here, and then we will pick back up with the regional center workforce initiative update when we come back out of executive session. Yes, I need a motion to enter us.
I make a motion to enter executive session immediately.
Okay, we have a motion and a second to enter an executive session. All in favor, please signify by saying aye.
Aye.
Opposed?
Aye.
Hearing none, we are moving into executive session.
Thank you. We'll track you down.
Yes. Now rise up out of executive session, folks. Yeah. Just a moment, if y'all don't mind. Yeah, she's supposed to be right now. That's what she's gonna get. David, are you online?
No. He needs to be.
We're just gonna get Commissioner Thomas on the phone, Christie. Get him on the phone. However you want to do it, so he comes through the sound. I'll just call him.
Call him.
Same link I gave him, but I'll just call him.
Hello.
Hey, Commissioner Thomas, this is Stephanie. We just want to make sure you're on the line.
All right.
Folks, we are now coming up out of executive session. No decisions were made, no votes were taken. We are simply here, we simply got legal counsel from our attorneys, and we are ready to proceed, move forward.
Madam Chair, I'd like to make a motion to amend this agenda to move item number 14, our action item, to right now, and then pick back up the rest of the agenda after that item is moved earlier in the agenda.
Okay, is there a second to this motion?
One second.
Okay, second from Commissioner Thomas. All right, is there any discussion on this matter?
It just means that 14 would move right above.
That's correct.
H.
14 would be moved right above H.
Correct, for the record.
That is correct.
Okay, moving on. Thank you.
All right, all in favor of this motion, please signify by saying aye.
Aye.
Thank you.
All opposed, nay. All abstaining.
Same.
Hearing that, the motion carries, and we will amend this agenda.
Because we have 2/3 vote,
That's correct.
correct?
Correct.
That's how you amend the agenda.
That's right.
All right.
2/3 motion to amend. Okay, so now we're entering into the public session. The action item is to deal with the personnel matter related to the position of state director pursuant to hearing court order of August 12th, 2021, and South Carolina Code Section 4420-220.
I would like to make a motion
Yes, sir.
pursuant to that court order of August 12th. And my motion will be as follows, which should be precisely put in the minutes as the motion is on this sheet of paper, which I will give to Christie to put in the minutes. And after this motion is made, I would ask that according to section 30-4-90 of the Freedom of Information Act, that the votes would be taken by individual member and will be recorded by individual member in the minutes. And this is the motion. Pursuant to the specific authority granted to the commission pursuant to South Carolina Code 44-20-220, which states in its relevant part that the commission shall appoint and shall at its own discretion remove South Carolina Director of Disabilities and Special Needs, who is the Chief Executive Officer of the department. I move to terminate the employment of Mary Poole as State Director of the South Carolina Department of Disabilities and Special Needs effective immediately.
Are you done?
Yes.
We have a motion and a second on the floor. Is there discussion on the matter? Yes, Commissioner Mill.
As was previously voted by me, I'm in opposition to this. I feel that right now, my major concern of this procedure of going forward this quickly with this is the effect on our staff and our members of our community. That the order that came out that was delivered, talking about the illegality of the action that was taken, be followed up by this vote, in my opinion, could have nothing but a negative impact on the morale of our agency. And I add that to the reasons why I will be voting no.
Okay. Any further discussion?
I concur with that assessment, and I'll be voting no.
All right, we have a motion, a second on the floor. Is there any further discussion? Hearing none, we're ready to move forward with the vote. This will be an individual vote by commissioner. We'll start with Commissioner Miller.
Aye.
Commissioner Malfris.
Aye.
Commissioner Blackwood.
Aye.
Commissioner Thomas.
Aye.
Commissioner Cohart.
No.
Commissioner Lamel.
Nay.
Commissioner Rawlinson, yay. By motion of the commission, this motion carries. And 5-2. Please note that in the record.
Individual member again, please.
All right, we will proceed now with number H on the agenda, Regional Center Workforce Initiatives Update by Mr. Rufus Brett.
Afternoon. You'll have in front of you a packet of information. It's a DSP survey that was published by Relias that talks about the factors contributing to the attrition and retention of direct support professionals. Felt like that would be timely given the challenges that we're having with our workforce. Last month, we covered a number of the initiatives that we've employed to mitigate chronic workforce shortages at our state-operated facilities. We've also shared the plight of our provider network, who also have similar challenges to maintain staffing. In fact, this week and last week, several providers are reporting unprecedented workforce losses and challenges, to the point that some are considering consolidating homes and closing homes temporarily. Some that have vacancies can't support individuals in crisis because, again, there's not a readily available workforce to fill the need and fill workforce voids. So having said that, I won't rehash the initiatives that we've employed, although, again, every week we're engaging parents and frontline workers to talk about initiatives and things that we can do to support them. We have a lot of work ahead of us, and so we're not denying the fact that, again, there are challenges that remain needing to be addressed, and we will address them. There were a lot of good suggestions that came out of the task force yesterday regarding ICF reform and improvement. I think that there are going to be some parallel initiatives throughout the provider network and internally and external to DDSN, because this is a multi-pronged, multi-agency, all-inclusive initiative, because it's going to require all of us to promote systems transformation, at least to the degree that we're trying to. So having said that, today I want to talk about, and I was late coming in because of phone calls relative to, some of the challenges that we have now with the current workforce working extreme hours. I mean, it is a fact. And it is something that we want to make sure that we preserve the workforce that we have in place. And despite some of the recent adverse events, which we have zero tolerance for, and will continue to purge our system of folks who mistreat individuals in our care. But we have a lot of dedicated members of our workforce, and we can't let the negative actions of a few diminish the many good works that occur day in and day out throughout our system. Having said that, for our workforce, I think we have an immediate duty to show support and recognition of our current workforce, particularly those on the front line, but we have a number of folks that support people on the front line. maintenance personnel, housekeeping, food services. Both Commissioners Robinson and Commissioner Core visited Salibi and Midland Center respectively, and I think they saw some of the complexities in operating these large facilities. Not to say that, again, in the future, we'll maintain the same number in size, but right now we have a dedicated workforce, and we have a workforce that is requires an interdisciplinary team to manage all the day-to-day functions and operations in serving some of the state's most vulnerable citizens. So having said that, I respectfully would like to at least posit with the commission a plan to implement an immediate recognition of our current workforce at the regional centers to show our support for those folks who are coming in under very, very dire circumstances and challenges as we try to reform and support them through multiple ways and multiple initiatives, but to implement a recognition bonus that recognizes their contributions to maintaining vital operations. And with this bonus, it's going to be, again, more inclusive than in the past, because again, it's not just frontline workers. We've concentrated a lot on direct support professionals and nursing personnel, and again, they are a key, but our maintenance personnel, housekeeping, food services, particularly now as we see a surge in COVID positivity rates, housekeeping, they're responsible for a lot of the disinfectant practices, and so they're putting themselves in harm's way, and they're some of the lower paid folks in our system. Food services, those individuals have been excluded in initiatives in the past. And so we're requesting a $300 bonus for over the next 30 days so that we retain the workforce that we have. Well, again, we can debate the time frame. If you want to go 60, we can, if that's the pleasure of the commission. But again, I feel like given the surge that we have in COVID, we need to do something that's immediate in the next 30 days, really 30 to 60 days are going to be critical for what we have. So we have the operating dollars to absorb, this initiative. We're talking $300 for, again, folks who are very, very dedicated. And again, it's going to be for the frontline workers to include the ancillary support professionals, trainers, mental health professionals, because again, those folks have been overlooked with past initiatives, administrators of the day, and folks who play those important support roles day in and day out.
Is anybody excluded? I heard the inclusion, I didn't hear the exclusion. Is anybody excluded?
Yes, facility administrators, the leadership roles, which I'd love to do something for them. If we want to do something across the board, we have right now a workforce of about 1,300, and this will be all FTEs or full-time equivalent positions, not temporary workers. So if the commission's will is to make sure it's all inclusive for the entire workforce, again, you're looking at 450,000 roughly.
And why are we excluding leadership?
As is because leadership comes with
They're working just as hard as everybody else.
They are. Hey,
With leadership comes responsibility, and they have to take on their responsibilities.
Yeah, but not 24/7.
Although they actually do work 24/7 whenever they're on salary the way they are.
but again, I'd be supportive of that as well. It's the will of the commission.
Anything else, Rufus? All right, what's the pleasure of the commission?
Madam Chair, leadership is important, no matter where I sit, because if I got to work 24 hours and they have to work 24 hours, maybe we should look at going across the board. That's just my opinion.
And how will this be instituted? I mean, for example, if someone comes to work today and they're here in 30 days, do they also receive the bonus? How does that work?
We set the parameters. If we approve it today, we could say from August 19th through, September 18th, that if you're employed on September 18th and you've worked throughout that entire period, maintain your employment with the agency, then you qualify for the $300 bonus.
If you're not on probation, in other words, you just started.
Yeah.
If you're not on probation.
That's fine.
We can put that stipulation in there.
Yes.
That's fine.
And I thought it should be 60 days because we want to encourage people to get through this difficult period we have now.
I think we do something at 30 and something at 60. Is that correct?
We can do something.
We can divide it. We can divide it. That'd be great.
Yeah. So with 60-day bonus with $300 payment at 30-day intervals, $300 across the board. So if you say 30 days, $300, and 60, $300.
Well, that's not what she said. She was saying if you were going to do a $300 bonus, it'd be $150 for the first 30 and $150 for the next 30.
I'm not opposed to what Rufus said.
particularly if we're.
I'm sure you're not. But what I'm saying is that's what she just said.
I was asking, I didn't.
We have the resources.
What are the parameters as far as the maximum bonus we can give? Where did the 300 come from?
The 300 was just a conservative amount to do it within existing operating funds without, tapping in, because providers are waiting on approval of the enhanced FMAP, and so it will be, it will create inequity if we started tapping into enhanced funds and the providers aren't. So we're taking this out of our own operating dollars.
What's the maximum our operating budget can handle?
Well, right now we have so many workforce voids, ebbs and flows, but last year we had a surplus of about 2.3 million roughly.
3 million
excess last year, but again, largely due to so many unfilled positions.
Madam Chair, I'm not opposed to the 300 if we did it 30 days and come back and look later at the 300. I'm not opposed to that, because here's what we got to consider and think about. If the management is not there, because they overworked, and you have the others, you still got a problem. So I would not be opposed to, let's do the 30 days at 300, and then Mr. Brett, Director Brett will tell us where we are before we get there.
Can we come back to the next, can we do that and then come back at the next commission meeting and look at it then and see where we are and how our retention, if our retention has picked up?
Yeah, and we're also employing some other initiatives too, so I think it'll be a good time to get some updates on the other initiatives to see how they're working, and hopefully we'll have a positive report in terms of at least onboarding. Some of the initiatives are showing promise to where we're starting to at least get applicants. So that's promising. So yes, that's.
We don't want to put him in a position where he comes back and we blame him.
You can do that. That's
I don't think you have to worry about that.
Well, let's look at this and is there a pleasure of the commission? Do I have a motion on the floor anywhere?
Motion would be to do the 30 days at $300, and then Director Britt will get back to us prior to that and tell us whether or not we need to go with the other additional 30 days.
Okay.
And it would be paid at the end of the 30-day period, not at the beginning of the 30-day period.
That's correct.
Correct.
And is this motion including leadership?
Yes, I included leadership.
Yes, he includes everybody.
Everyone.
Okay. Anything else?
You said conservative for $300. We're looking for goodwill for this and show them we appreciate it. Is that enough to get that, to accomplish your goal?
I think so.
And if we run into a problem, the Director Britt can come to us and then tell us, hey, this is where we are. And then we're open-minded. We can adjust.
That's true. We just have to be careful because we have a lot of providers, thousands and thousands of providers, and we don't want to exclude them, and we can't afford to include everybody that works in this agency. So you have to be very careful how you do these kinds of things. I know it sounds good, but it's just like whenever we decided to do the bonus for somebody getting the vaccination. We couldn't afford to do that across the whole agency. So we didn't do that across the whole agency. We did it for the ones we're doing now. So we just have to be careful how we treat some people over others, which is what this commission has had so much trouble with over so many years.
Well, I disagree with that. Those providers are not our employees.
No.
The ones that we're paying here are our employees, our direct we have direct supervision over these employees. And I feel like, if the providers want to give bonuses to their folks, then they can do that. If they wanted to give a $150 bonus for getting their vaccinations to their people, they could do that. That's their board's decision. That's not our decision. We have no control over those local boards. And I think we can't compare ourselves to those local boards. We have no authority over them other than we help them with their money. And, that's not our business. I mean, what they do with their employees is their business. It's like, I just feel like these are our employees that we're doing.
I can report that many providers, not just boards, they're experiencing the same thing. So they're employing a lot of initiatives. We dialogue all the time. So whatever we do, we share with providers, they share with us, and they try to mimic when they can. And again, so many are employing similar initiatives and similar strategies. Again, so it's not a one size fits all, but all employers, I think, is incumbent upon all employers to, at this point, to really, particularly in the healthcare field, we have to do something to show recognition and appreciation of our workforce.
Okay, we have a motion on the floor. We have a second. Do we have a second on that, Robin? Did you second that?
Yeah, I'll second.
Okay. Oh, I thought you did. I'm sorry. All right, so we have a motion and a second. Any further discussion on this matter?
Are taxes withheld from this money? Or is it?
That's an HR question, but I would imagine so, yes.
Gary Mill.
And I just want to make sure that Christie's got it down effectively. I know she was. Okay, that's, I want to make sure, so. Okay. You have it? It's in the recording, okay.
It's in the recording.
Okay.
All right, so we have a motion and a second. No further discussion. All in favor, please signify by saying aye.
Aye.
Opposed, nay. Abstentions. All right, hearing that the motion carries, we will proceed with the $300 bonus for our employees. Rufus, before you leave, I have some questions. Do you have more that you want to present on, or can I ask some questions?
I'll answer your questions.
Okay. I know that we are in a staffing crisis in our regional centers, our ICFs, across the board. We're in staffing crisis. How are the bonuses for nursing working? How are the bonuses do we have bonuses in place currently for DSPs to get them on the onboarding kind of things? I know we give a signing bonus, and I know we had talked about putting something together similar to what other state agencies were looking at. Can you tell me where we are in that process and what's going on to try to help solve that problem?
Yes, last month in your binder, you received an exhaustive summary of all of the bonuses and workforce initiatives.
Okay.
And so, and again, we've employed a number of initiatives. And since then, we've engaged some of the families, the Witten Center Parents Clubs, in a very, nice, constructive letter saying that, hey, in the past, we had these positions. So we're looking there are multiple initiatives, but we're looking to reconstitute some key initiatives to address, health and safety, on-the-job training, because when we engage frontline staff, it's not just, hey, we're working a lot of hours, but also, hey, everybody's in coverage. So if I'm new, the person that was responsible for training me is also in coverage. So that's a collateral duty, or a collateral circumstance that a lot of agencies are facing, that the people that help make sure folks have the competencies to do their jobs are in coverage and they're working extended hours. And so to answer your question on the nursing bonuses, the $3,000 sign-on bonuses that the commission approved a few months ago, it's had some effect, but it is not competitive when you look at what hospitals are paying. And then some of the other state agencies have employed more aggressive bonus plans. And so that's something that, again, I think we have a number of things that we need to evaluate. One is right sizing, and so we have an initiative to where we're looking to solicit interest in folks living in smaller settings to include returning home to live with families when that option exists. We're looking to consolidate dorms like some of our providers, because again, we have to have the economy scale and right mixtures of folks living together. But with this shortage, we may look at organizational structures, to see can we do business differently.
Okay.
Yeah. So,
So right now, we're okay.
I'm not saying we're okay. What I'm telling you is that there's so many things that we're evaluating at the same time. And again, when I tell you that there are a lot of people swinging the bat, not everybody, but there are a lot of people swinging the bat, doing more than their fair share. And it is exhausting, in particular for folks in leadership positions. So I want to and that's just not at the regional centers. That's folks at Babcock Center and Disability Board of Charleston and Tri-Development Center. I hear it weekly, from our colleagues. This is a national crisis. I know folks like to.
Well, I know in Florence, they're having to take people from the day program and send them to, ICFs. I'm sorry, I couldn't get it out today. To ICFs because they need them there. I mean, and thankfully, those wonderful employees in Florence have agreed to go down and help out with that. So apparently it's happening across the state as well. And there's, I just want to make sure that, we're doing everything we can to staff those ICFs so that we don't have to move employees around. But obviously, we got to have them where they're needed right now.
And maintain health and safety, but also too, for, again, and it's not just, I don't want to be centric on residential and day providers. Families are struggling too. Families are struggling to find caregivers. And so we have to look at the needs of all of our stakeholders and all of the folks that receive services. And so, again, I know we spend a lot of time, talking about these initiatives, but again, it's because we directly operate them. But we can never lose sight of the folks that we have more people living at home with their families than in residential settings.
It is very hard. It is very hard to find.
So there are a lot of competing priorities and a lot of folks, again, working tirelessly. The lights are on here a lot of times well after 5 o'clock,
I know one of our callers said something about, the rate of pay on that. And are we addressing that and working to try to get that increased? How do we do that and that kind of thing? What has to be done to get that done?
That has a brief presentation on one of the in-home supports that's very valuable to families, respite care. We feel like there's definitely opportunities to increase the rate. The General Assembly saw fit to appropriate recurring appropriations to DDSN to help do so. As Pat mentioned, the folks over at Health and Human Services have been so good to work with in helping us modernize a lot of our service lines and have rates to align with needs and increase to meet the growing needs of our providers and our folks in our network that we serve.
But technically, that is an HHS decision.
It is, unless they.
And do we encourage them, or do we provide backup for them or provide information to them so that they know to do that? Is that correct?
Yes, we've been meeting with them. And again, I don't want to preempt anything Pat's going to talk about with his presentation on respite, but we meet monthly, not only with them, but with other state agencies. And so right now, there's a lot of collegiality and synergy, I think in state government, which is very, very positive.
That's great. No silos. That's what we want. Now, let me ask one more question. When it comes to salaries, I know our nurses start out here and hospitals are starting their nurses out here. Can you kind of give me a number where we're starting our nurses and where our nurses top out compared to where hospitals are starting nurses and where hospitals are topping out?
Yeah, the last time we looked at the Bureau of Labor Statistics results, I think the median salary for like an LPN was around 45. Don't quote me on that, but we started at 41.5, I believe, at DDSN for LPNs, and I believe it's 53 for RNs. And of course, that is, state government is usually not competitive, with private industry, and there's some reasons that justify that. But I think there is at least a reason for us to continually evaluate wage and parity, which is real pleasing that there's a specific task force that's going to address those issues.
Good, okay, that's great. Thank you so much. Oh, I'm sorry.
So the last time we went to the legislature, gave just a straight pay increase. It was the $3 over 3 years. What was that? Was that 2019 was the last increase that we got from them, or was it 20? Do you remember?
That was a 3-year initiative. I think the last dollar increase was 2019, getting the DSP, and that was specific to direct support professionals.
Right.
What Commissioner O'Malley was talking about, to get the entry-level salary at $13 an hour, which in that report, you'll see that I think the median salary based on their study was around $12. So it's good to see that South Carolina's ahead, but still $13 is not a livable wage.
And as I recall, that was sort of a direct response at that point in time. Walmart was paying $12 an hour.
That's right.
That was sort of the justification with the legislature. We at least have to be able to have enough to match what Walmart's willing to offer somebody.
That's right.
Walmart's doing between 15 and 20 now as a starting point. So I think we as a commission, when it comes time for the next budget request, we may have to go make that same presentation of we're competing against retail to some extent for our DSP.
We're competing for McDonald's. I mean,
Right,
McDonald's
exactly.
starts about $15 an hour, plus gives them a $500 signing bonus.
And for again, you all just visited the regional center, so you saw, it's a lot easier to look at paper and reports and charts, but when you look at people and the level of care and the complexity involved in serving some of the individuals.
And the numbers that they're having to take care of right now, because we're low on staff. That to me was very shocking. I didn't realize how low we were staff-wise until I went in to Saluti and saw.
Yeah. And some of those same individuals are living at home with their families. And so trying to find a caregiver to maintain people in home that have complex needs, I mean, it's doubly tough. So again, we have a lot of work ahead of us.
Okay. Very good. Thank you, Rufus. Any other questions? I'm sorry. Nothing? Okay. Thank you, Rufus. Thank you. All right, Pat, we're going to bring you up to talk about the spending plan, or respite overview.
All right, I am
I'm between you and the finish line. So,
Actually, Lamb's Road, I'm sorry. I'm two items ahead.
first topic is just a routine surplusing property of Lamb's Road in North Charleston. That's a facility that we owned. The Charleston Board has moved its 8 individuals out of the CRCF into 2 4-person homes. They got each $100,000 loan from the Housing Trust Fund. They put substantial funds of their own into these new homes. And now it's time to, they've moved into the new homes, so now it's time to liquidate the CRCF. And by policy, the way we liquidate a facility that we own is we surplus it to the state. The state sells it, and they get half the proceeds, we get half the proceeds. And our policy is when we get half the proceeds, we then roll that equity back into the provider's new facilities, as long as it's equal or greater to the facility they gave up. So by surplusing, it starts that process. It's a property clear of mortgages. It's exceeded the 20 years required for the housing trust loan that's on it, and its appraised value is $230. So with some luck, they would net $100,000 plus toward the 2 4-bedroom homes they have purchased. So I request a motion to surplus the property at 4788 Lambs Road, North Charleston.
Second.
A motion and a second on the floor. Any discussion on the matter? Seeing none. David, are you still on the phone?
Yes,
Okay, just wanted to make sure. All in favor, please signify by saying aye.
Aye.
All opposed? All abstentions? Hearing none, the motion carries, and we will move forward with that pattern.
Okay.
Next, respite.
The next topic is respite service overview. I will be backed up by Lori and Rufus, primarily Lori. What I presented you on the first page, which we'll spend most of our time talking about, is the quantitative information. And we'll provide you the narrative in between this so that hopefully when we get done, you will have a picture of the program, how it works. And this is all leading to the question, we've been given over $2 million in state funds that would turn into about $7 million of total funds when matched with Medicaid to apply to the rest of the program. And we have a couple of decisions to be made, or at least guidance given to me, because I have to start pursuing rates with HHS on our particular rate, and there's some decision points we have to at least narrow down. If you look at the top of the first page, in the first blue box, I think this is a very important fact. What you have there is $37,555,000 of current waiver participants' respite approved budgets. That's an important number, and you compare it to the second number, which is what did we spend in fiscal year 21, which was about $25 million. What that tells us is when our at-home individuals go to their case managers and they develop annual budgets to meet their needs through services, you add up all those respite budgets, it totals $37 million of need. What we found in fiscal year 21, we spent $25 million. So there's a gap of $12 million in budget need that is not addressed. Now, the question is, how do you interpret that $12 million? It had, on a spectrum, on one end, there is $12 million in need that if we had access and providers, our individuals would spend $12 million. Part of it could be in the part of the budget process, there could be a little, maybe the family got it, but has it on their budget just in case. And I'm not an expert in that, but I can tell you Lori is, and I'll speak for Lori. We spoke last night, which is she believes that the vast majority of that $12 million is actual need that is pent up in the system that families would use if they could get access. That's a key fact to remember going forward. And that's a liability financially sitting out there that if, we adjust rates upwards a little bit, we may create the access, which the good news is we get needed services. The fiscal issue is we got to make sure we have the money for it. And we have at least $7 million, and certainly with our reserves, we can cover other issues. Okay, the second block, a lot of numbers there, you can study them later, but I'm going to tell you what it tells me. The second block is a comparative of fiscal year 19, 20, and 21, all on 2 lines. One is the amount of services we provided. Fiscal year 19, we provided $20 million of service. Fiscal year 20, $22 million, went up almost 7%. Fiscal year 21, 25.4, it went up 13%. Okay, so even with a great need, it is going up at sizable clips. It went up literally 13% in 1 year. So, what's that? I don't know why. It could have been the labor force was not doing something else and they're available, any number of those reasons, but it definitely clicked up. The other thing you gotta look at, and this is important when we decide rates and how to set rates, is who is providing the services. And we have 3 primary service providers. The first group is called business providers. If you look across the top, you can see they control 38%, 46%, and 47% of the services provided. And it's increased 21% in the last 2 years. The middle group is self-directed. 37%, 37%, 34%, pretty steady in the middle. And the last group is board services. We have about 10 boards that still provide respite services. I think at one time, most all boards provided respite services. And there's a history behind why they got out of the business. Some of it's insurance, some of it's just the rate. But needless to say, we have 10 left. And you can see their declining involvement. They in 19, they had 25% of the services. In 20, 17%. In 21, 18%. So they've dropped about 28% since 19. And when you look at that, there's a couple other factors you have to put into play to understand, for example, the business model. If 47% of services come from a business, you may think that you pick up the phone and call respite ABC company. Hey, I need respite next Saturday, or I need respite every Saturday for 5 hours. That type of respite generally doesn't exist. What you see out there, and Lori, I want Lori to jump in here, but what you see out there is respite is a service that we pay $12.69 for. Personal care one is a service we pay $17 for. A lot of the home health services, literally, they will want you to maximize both services, and they'll provide you both services. But they're not generally set up to, if you call up, they'll provide you a respite provider. It's almost what you call it.
So the ability for Medicaid enrolled personal care providers to do respite is relatively new. It kind of came about at the last waiver renewal, so about 5 years ago. And we were very hopeful that that would open up providers that had not been there before. But because of the rate, the personal care providers are not really interested in creating a workforce of just respite. Now, what they will do is, like, if someone is approved for, 20 hours a week of personal care and 5 hours a week of respite, if they're doing your personal care, they may also take your respite, because 9 times out of 10, it's the same worker. And so they can somehow make that work in the negotiations. But there really aren't any of those providers that you can just call and say, hey, I want to receive 20 hours of respite for my family member, and that they're willing to go and find a respite worker.
So you understand the market, you understand the increase. And there's 2 more important things that we need to look at. One of them, obviously, is the rate, and we'll talk about that in a minute. But the other factor is, and again, I'm going to get Lori, she's much more of an expert than me. And just underneath where I had that first chart, you see in-home supports. In-home supports is a self-directed service. It currently is only in the CS waiver, but will be in the IDRD waiver January 1st, if everything goes well. It's currently in the Appendix K waiver, in Appendix K for the IDRD waiver. And what's interesting about the in-home supports and why it's connected to respite is it is a service that Lori will call it in lieu of service, meaning
you choose it within the waiver, the way it's defined in CS and the way that we're defining it in the ID waiver. Okay.
Come on.
Be able to hear you. So the way it's defined in the CS waiver and the way that we're defining it in the ID waiver is that it's kind of a combination service. So if you think about it, when a person needs functional assistance, right? There's a combination of helping you do something and then supervising you, right? So personal care and respite splits that out. How much help do you need, physically help with a task, versus how much time do you need to be supervised? So in-home supports combines both. And so in both waivers, you either receive in-home supports or you get a combination of personal care and respite. So you don't get in-home supports and personal care or in-home supports and respite. You get one or you get the other two. Okay.
But the key element of the in-home support, just for the simple person like me, is hiring the caregiver. If you hire the caregiver through in-home supports, they haven't lowered the required criteria, but they've made it easier to get caregivers on board because families are hiring them direct. Families know who they hire, and if they hire a certain range of immediate relatives, there's little of any.
They can waive requirements.
They can waive requirements. And if you hire someone at your church that you know, you still have to do a background, but you do not have to go through the equivalent of the Respite Coalition where you get the TV shots and the training and the annual surgery. So it's easier to handle onboarding caregivers through the in-home support. And just as an example, Appendix K was put into effect essentially July 1st of last year.
Right.
And our in-home supports jumped from 4.5 million to 6.7 million. And that's mainly because the people in the IDRD waiver before didn't have access to that, and they were able to get that service during COVID. And also, I think the requirements were they're able to hire closer family members that they ordinarily couldn't under normal circumstances. But the whole point is, if you want to provide access, you can raise the price and hopefully attract more businesses into the fight, or you can ease restriction. Don't mean to say that.
No, it's not easing restrictions.
You're easing.
Streamlining the enrollment process. You're making it easier for people to access it.
Well, you're getting caregivers in who you know and not putting them through the same gauntlet that you would for respite. So,
okay, I've got a question. When you do that, when you get them in, a lot of them still have to take this CPR, they have to take the first aid, they have to pay for the background check and all this kind of stuff.
Not in-home supports.
Okay, but how about respite providers and the others? See, they're still having to pay for that stuff. And that's expensive. I just went through it with a student and I'm still paying.
So we do
I've got
have
another background check.
So we do, this is kind of off to the side, but we also do have household employer assistance funding here that you can apply for to be reimbursed after they pay for it.
We need to make that.
Do case managers know all this?
Yeah, because they're not telling people. I will tell you.
We need
maybe
they need a public awareness campaign on some of this stuff, either externally as well as with case managers.
So like I said, in-home supports has been a very restricted service only to the community sports waiver.
Right.
So that's kind of something that people in the head and spinal cord injury and intellectual disabilities waiver haven't had access to until Appendix K. And it did make it applicable to all three waivers, at least during the public health emergency. So as a result, it was very well received. We had a lot of people enter it for replacement services during Appendix K, and they've realized that it's a lot easier to do self-directed services that way than through the respite program. And it's easier to kind of have the same person do both personal care and supervision.
We do need to look at something, Pat, to cover these costs for these people because that's what's keeping these people from doing this. Because I'm telling you, after you pay all the cost for them, it's $700. And for a young person that's trying to get into healthcare or is in college trying to do respite care on the side, that kind of thing, they can't afford $400 or $500.
We can send something back out, but we manage it centrally, so it's not at the agencies and it actually comes into my office for.
But it's on the back end.
Right, correct. You have to pay for it first and then you get reimbursed.
We just need to make sure they know they can get reimbursed because I don't think they realize that. They're not being told that.
You referenced care monitoring process. What do you need from us as a commission?
So, you mean what?
You're dealing with rates, and you mentioned care monitoring process. Pat was using one word, you said not to use that word.
Oh, he was saying reducing requirements, because we're not reducing requirements. We're just, so I think Pat's point is we have to do something to increase access. And the only way that you're going to increase access is you're going to raise the rate, because, you know, if you pay people more, people get, you want to, the other thing is businesses, if they have a competitive rate, maybe we would get to a world where a business said, I'll go recruit and hire a group of people that are interested in working for folks. So when somebody calls me on the phone, I have a worker pool. And then the other way is to kind of make it more streamlined for people to actually become caregivers in the self-directed world. Because what I think you're talking about is there's a lot of hoops to jump through in order for people to become certified respite caregivers.
So what's the plan of action?
We'll get to the end and finish line.
Okay.
Let me just get through a few more facts. Okay.
You want me to sit down?
You stand right there. You're right.
Okay.
You're good. You're good. There's no mic here to fight over, okay? You're closer to the green halo, sorry. Boards, 10 to them. 3 of the boards have what I would consider a model that's becoming less, it's almost going extinct, which is basically they recruit people and then they hook people up to families in need, and their employees will serve multiple families. It's almost like, that's the ideal model, I would imagine. It would be most advantageous to families. That is the minority model. Most of them basically will help you if you bring your caregiver to them. They will act as a third-party intermediary. They'll run payroll for you. They'll do all that. And quite frankly, all these boards are, in my opinion, doing it at a loss. They're not making any money off this. Matter of fact, I know they're losing money, but they're doing it to serve the community. And then when you go over to the self-directed way to provide a service, which is the next bullet, what was interesting is they have 1,235 active caregivers, of which 196 or 14% actually will serve more than one family. So what that tells us is the predominant model is families find their caregiver, they run them through the self-directed and they serve the family, or you find the caregiver and you go to a business and the caregiver hires the business hires your caregiver and then gives them to you. So it's not, the model that we would like is make it rich enough so that we will have a provider network that will recruit an employee base so that the families don't have to go find their caregivers all the time. A lot of them want to find their own caregivers, but a lot of them don't have the capacity or capability to do so. And that's what we're trying to incentivize, that make that very small model now get bigger. And obviously, I think the boards are in the best position to do that. And we're hoping to incentivize the boards to get into this with our final plan. Let me get down to the third area. We took a look at the business providers. In fiscal year 21, we had 77 providers out there. And when you looked at it, it was really kind of surprising. 5 of them in metropolitan areas do 56% of the work. And so they must be big home health care providers that do the bulk of the work. The other 72 providers averaged 10 times less in revenue than the big 5. Very small home health care providers. I imagine they do exactly what Lori said. They do it just enough to balance out their PCA business as opposed to service respite. Okay, the last thing that you need to take a look at here is when we decide what we want to do. And there's 2 things that we want to do or suggest or recommend. The one is what I would call the long-term solution. The longer-term solution is have 2 rates, a business rate closer to $16 and a self-directed rate where we pay the caregiver a minimum salary. The current minimum salary is $11.30. That should go up. The question is, how high does it go up? And in an ideal world, the higher the better. But I think in the world that we live in, we have to look at our other service array, not only ours, but we have to look at what HHS does. We can't come in and pay our respite workers $15 an hour when our DSPs make $13 an hour. We can't knew that we can't, if we're giving money for this service, we can't move them to $15 an hour if our in-home supports are only getting paid $11.30 an hour. So the decision we got to make today is we only have one rate. In the IDRD waiver renewal, we're asking for a second service for a second rate. And hopefully that will come out. I'm not sure it will. Nothing's 100% guaranteed. But if that comes out and we get a rate closer to 16, now we're really in business. The second rate has to wait until January 1st. Our immediate decision we need today is we currently have a rate at $12.69. We pay self-directed workers $11.30. We have the money to raise that rate. We have the justification to raise that rate. And I need to make a recommendation to HHS what to raise that rate to. And there's two components to raising that rate. One component is, what do we want to make the minimum salary to the caregiver? I think everybody's in agreement. It's at $11.30 and it should go up. The question is, how far should it go up before it starts, A, affecting our other services, or B, encroaching on the business rate? And once we decide what that number is, and to me, my proposal is, if you ask me, $12 would be a range where we would not create inequity between it and a business rate. A business rate can still, a businessman could get $16 an hour and afford to pay somebody $11.25, $11.50, $11.75, cover their overhead and still be profitable. If we raise this $12 up so much, they're not gonna be able to compete, and we're gonna have the same problem today. Is the family's gonna really want to do the quickest and fastest thing, but to get their caregiver the highest rate, they may go through the internet process, which just takes a longer amount of time. So, and once we settle on what the rate is, then what we pay the caregiver, on top of that, we have to put our 15% self-employed business tax on top of it, and 40 cents an hour for our fiscal agent costs. Because we can't make any money out of this rate because of our administrative contract with HHS. But what we have to stop doing, which we've done in the past, is we lose money on every rate and it costs us state funds. So that's where when you go to the second page, which is and again, this is just an assumption. We don't even have to decide today, but we have to decide at some point. Or you have to give me some authority to talk to HHS, because they're the rate setters. They're going to decide it, but they're going to ask me, generally, what do we think? And what the second sheet is a rate sheet for a $12 an hour self-directed caregiver rate. And if you walk through it, it ends up being a $14.24 HHS rate. And the extra $2.24 is to pay the caregiver's self-employment, 15% tax, as well as 40 cents an hour for our fiscal agent. So that's our immediate question. And so I really just want to rather open it up, not make a proposal, is given the constraints on page 1, which is what other services have, what range of recommendations should I be considering talking to HHS about when it comes to raising the caregiver rate from $11.30 northward? And I believe 12 is a reasonable rate to find. It's a 12% increase. It's not $15. If you want to go a little bit farther north, I think all we do is we run the risk of encroaching on the business rate.
It's very important we not encroach on the business, because the business is going to be easier to get. I mean, the people are going to be easier to get businesses to help them out than they are to get individuals.
I would defer to Commissioner Blackwood, but we've had conversations where you're doing the paperwork.
The state you're in,
and I think too that some of when we talked about at the beginning, the gap in services, a lot of the gap are really those families who don't have a support network. They don't have anybody to bring somewhere and get hired. And so that's where the businesses come in, because if I can't find my own caregiver and get them and somehow get them in the system, self-direct is out of the question, right? You can't self-direct what you can't find. So, that's where the business comes in, I think. And I do think you're still gonna have trouble in depending on what area of the state you're in.
To the chair,
Well, I suspect $12 is reasonable.
Yes, sir, Mr. Miller.
then why don't we deal with the $12 and give them the authority to discuss, have talks with HHS?
I'm here at your pleasure. All you've got to do is make a motion.
And what we say is not binding on them. They just want a starting point. They may go up or down. It's their waiver and they're the rate setter, so
Okay.
it's just some place to start.
Mr. Chairman, what is the pleasure of the commission?
I'd make a motion to make it $12 and to discuss it for the HHS from there and see what they come back with.
For the in-home supports.
So the in-home.
I'll second the motion.
Any discussion on this motion?
So are you raising the business also?
I am standing here and Lori's calling a play in my ear.
That's good.
And the in-home supports is 11:30.
Okay.
And the reason I think we should bring it up, but I believe that when they add it to the IDRD waiver, they're also going to reset the rate. That's my guess. You don't know? Okay. I'd like authority to talk about raising the in-home supports to 12 as well. Because they're the rate setters. It is right in the middle of the IDRD waiver. I just had an assumption that they were going to not only move it in, but also come up with a rate, but let's just.
It's at 1331 anyway, which is like respite's at 1269, I think, right?
Yes.
So in-home supports was already at 1331, so I'm not.
I recommend that we talk about raising them both. And from a financial perspective, the $7 million that we got, if you look on page 3, I'm not going to, there's too much math on page 3, the money that, the 7.2 they give us would fund the $12 rate, it would fund the $16 rate with a 7% utilization increase, and it would end up paying, instead of 7.2, closer to maybe 8.4. The only thing I caveat this with is, and this is where all the complexity comes in, is when we implement EVV on January 1st or early next year, I have every expectation that utilization will go down. Not that people are using it less, I just think some of the current laxities in the paper process can no longer be tolerated because people have to literally be on station at work with their smartphone or login to be paid. And so historically, when you add EVV, utilization goes down. Not that people aren't using it, it's just.
What is EVV? Don't do these things.
Electronic visit verification.
Thank you.
Everything will be recorded. There'll be no more paper logs. And you have to show up, the GPS on your phone will tell you you're there and your clock starts.
Okay.
So I think financially we can cover respite. In-home supports, that would be another expense, but they are the rate setters. And I believe in the short run, if they raise the rate, we can afford whatever that differential is from our current reserves.
Okay, Mr. Miller, does your motion stand or do you want to amend it?
I'll amend it based upon what.
I made a
just
motion.
said.
I'm sorry, I couldn't remember who made the motion.
Pat made the
All right,
motion,
all
I
right,
made
so
a suggestion.
Can you repeat your motion?
Well, I'm trying to. What I was saying is I wanted to make it $12 for the in-home supports, I thought. It was for 1140.
Respite was our number one issue.
Right.
And when you brought up in-home supports, bells went off up here. And even though we don't have funding for it, dedicated funding for it, I believe it is a decent recommendation so that we keep these in-home supports equal. And if we keep them equal, it increases access for both. And any extra funding that falls on the in-home supports, we have ample reserves to cover if HHS rate setters are so inclined.
Until January, you're saying cover it until January.
Well, we have to cover it forever. All I'm saying is.
Right, we have to cover it forever. That's what we got to be careful of.
Some assumption on my part, they were going to adjust the rate anyway because they're adding it to the IDRD waiver.
So they will adjust the respite rates in the ID waiver as far as we know.
Right,
I don't know about
And-
it.
So we're saying they're going to
We don't
adjust.
know to
both
what
those
extent they're
to
gonna, we don't know to what extent they're gonna adjust it though.
That's the reason why we're giving Pat the authority.
What you're doing is voting to give him the authority to negotiate with DHHS
And you come back
to
to
bring us $12 rates.
Well, the exact way I put it is, the General Assembly has given us funding to address the program, to include raised rates, because that was part of our presentation. And what we're also saying is, by the way, this service is identical in most every respect. Let's just go ahead and do both of them. And if we did not have the reserves that we had, I'd be hesitant to do it. But we do have tremendous reserves that could support any incremental increase in the in-home supports. So I think that is a good.
So both would be 12, or, because I thought we just said one was above 12 already.
Because they're both the same service, kind of, right?
12 means pay to the worker. The other rate, like right now, the Medicaid rates that include the tax plus. Help me.
Currently in in-home supports, we pay them $11.30 and we have a $13.31 rate.
Right.
We probably pay $13.60. We lose a little money on that rate. So if we move them up to 12, we'd have to move the rate up to $14.24, just so that we're whole. And actually, and if we do that, quite frankly, the money that we stop losing would probably pay for the increase.
Okay, I have no problem with that. Okay, well, then we're gonna move both of those to $12 and make it $14.24 with the total.
That would be our.
With the rate.
That would be our proposal.
And we'll reevaluate this. We must, but under the caveat that we reevaluate this before January 1st to make sure that our rates are gonna go up.
Or once we know what the rate.
I think what we do is
Once we
give
know
them,
what the rates are.
we give them the authority to go and
Right, make the suggestion.
then they'll come back to us.
Yes.
Right, and then you come back with us with the final.
Yes.
Okay.
Yeah.
Thank you.
All right, we have a motion, second.
You got the motion, Christie, that's not an easy motion, you know.
I'll make it up later, don't worry about it.
That's a tough motion.
That's what I'm
So
talking
we have a
about.
motion, do we have a second on this motion?
Second.
Okay, second from Commissioner Blackwood. All right, any more discussion on this matter?
One question I've got, Pat, is at what point is he going to be able to come back to us with the results of said negotiations? Or do we need to say we need an update on this in 60 days and 90 days and 6 months?
They are right in the middle of the IDRD waiver renewal. I believe they may have already, they're holding it closely to the vest for a lot of logical reasons. And for all I know, they've already started doing that. We just want to be able to say, they know that this legislative issue is coming. We're going to say, look, if you're not already looking at in-home rate, we want you to look at it too. And then they have the ball, and the next time you'll hear about it is in the IDRD waiver renewal. Here are the rates.
So we don't need to put anything in there about it, come back to us and send it.
You're just giving me the authority to suggest, not to demand.
Right. Okay, I got it.
Okay.
We all good? All right, so we have a motion, second. Any more discussion? All right, hearing none, let's vote to give them the authority. Vote. All in favor, say yay.
Aye.
Aye. All opposed, nay. All abstentions? Hearing none, the motion carries, and Pat now has the authority to take care of that.
Okay.
All right, Pat, next item is the
Spending plan. I want to thank Nancy Rumbaugh downstairs and Budget for helping me build this, and we really had to almost reinvent it, given the fee-for-service world we're in. And plus, we have to get maximum transparency on all of our expenditures. Not that we're not transparent, but we can always do more. And with this budget, I hope that every penny that I can lay out, you can see it and you can talk about it if you want to talk about it. You may not want to talk about it. But the first document you have is a spending plan summary. That's your traditional one-page spending plan, revenue, 8 or 9 categories, with obviously Medicaid and state funds being the most predominant. And on expenditures, you will see our expenditures. We tried to keep them very specific to the services that we offer so that you can process of the money that we spend. You can see where it goes into those services and hopefully help you build the framework of how we operate. To build this plan, you have to go to the second page, which is the more detailed spending plan. And what I did on the left side was I list every possible expenditure and revenue source. And the reason I did that, it is somewhat unusual, but we're in an unusual business where most of our expenditures generate our revenue. Meaning I spend $1 on Medicaid, I get 70 cents in revenue. I think it was very helpful to illustrate that so that when you look down and see all of what we do, I would say 85% of what we do is Medicaid expenditure for every dollar and 70 cents, or with the FMAP, 72 cents or 86 cents in revenue. So the first column is what I call the fiscal year 22 operating baseline budget. All we did was we took what we spent in 21 and we rolled it to 22. We made no adjustments for overhead. The only adjustments we made were for logical upward trending utilization. For example, if you look at respite, I'm hoping that number is somewhere around $28 or $29 million. $29 million. Okay, you just saw it was 25.5, 25.6 in 21. It's going up at a good clip every year. So I had to factor that into our budget because that's where the trend's taking us. Beth, where's that $3 million going to come from? The answer is we've not done a good job at asking for appropriations for utilization increases. And starting this year, we're going to do that when we turn in our fiscal year 23 budget, that we will look at our last 3 years of expenditures and come up with, hey, this is utilization increase that if we don't get funded for, it comes out of our base. And so that gives you just a view of what 22 would look like based on 21 results. The next line was I added in our appropriations. And 6 months ago, I didn't think we were getting any appropriations. And now you're looking at $23 million in appropriations, 17 million recurring, and the difference in one-year funds. The 2.5% COLA, it covers another percent for pension, adds some for health insurance. That's adding another $12 million in there. So you're adding $35 million on top of our budget, and we're ending up with close to $850 million. And the last category was what I call fiscal year 22 increases, which are staff's recommendation to our baseline increases. And you can find them on the next page where we itemize them, and that's $3.9 million. And predominantly they're in the community and regional centers. And I'll just, you guys had this for a week. We can ask questions about them. I don't want to go over each one individually, but I have Mike here because Mike spends most of our money these days. We are trying to intentionally upgrade our technology because as a healthcare organization, if technology is going to make us more efficient and effective, and Mike's doing a great job at finding areas to simplify and reinforce. So we have 7 items totaling $700,000 from Mike, which we can talk about. We have a part-time, a temporary 10% FMAP project leader. I felt like we had to have a single person that's always there supporting all 10 budgets and all the task forces when it comes to not only spending the money, but more importantly, the accountability for the funds. And there will be a certain administrative component here as once things get rolling, this person can be part of the project management coordination, but we have to have one person to serve us because literally you start handing out these collateral duties, we end up getting, I think, bad service, not because people are bad service, but they got 5 things to do. We're adding a procurement supervisor. As a little bit of a misnomer, we've always carried 5 people in the procurement office. We went down to 4 for the last year and a half, and we need 5. And the reason we need 5 is because we are a contract business primarily, other than the regional centers, and then even at the regional centers, they do a lot of contracting for their services that come into the facilities other than personnel. And I'm a firm believer, if we had a little bit more horsepower in procurement, we could pay for that job many times over because we are really not getting what I would consider the deliverables or the critical thinking in building the right contracts to get it at the most advantageous price. A lot of times we're rolling over contracts because we're doing the same thing we've done for the last 5 years. And we just need more capability to look at everything holistically so that when we contract for physicians, nurses, all these positions, we can make better decisions as to, are we going to have an FTE, are we going to contract it? If we contract it, are we getting the best price, or are we getting the convenient price? So I believe it's important to add a little bit more horsepower. This person would be under Candace, and Candace, it would free her up to do what I would call the business end of contracting, where you're actually you're actually building contracts to get greater value out of the contracts. So that's our recommendation there. And then $100,000 for the continuation of the temporary contract group that Lori has. As a reminder of that, this popped up during the COVID. At that time, I'm just using rough numbers, we had 37,000 people eligible for services, and we had probably 20,000 plus in services, and the question was, hey, what's happened to the other 17,000 people? You know, let's touch them, let's make sure that they're okay. And we knew that there was I guess, dust on those other 17,000, like maybe they weren't all up to date. I think we found that they were less up to date we thought. So we're literally going through those 17,000 and cleaning them up, finding people. And I think, Lori, if you can give just 30 seconds. I think they're finding people and actually finding people in need of services and
Sure.
get them hooked up.
Sure, we're actually going through them one by one and making contact. And we're trying to find people. Sometimes we find people and they didn't know they were eligible or they didn't know who to call, and we're able to hook them up with case managers. In other circumstances, we're finding that people have moved out of state, that they have passed away, that nobody's tried to reach out to them in 10 years and they don't live here anymore. So we're able to kind of remove those people from waiting list. Really what it's going to do is help us have better information long-term about the people that we have that are waiting for services. It's just taking longer than we initially had thought because we spend an awful lot of time looking for people.
And then, Bill, one of the things we need to get better at is constantly reconciling what we do.
Sure.
And I think when we don't reconcile, things build up and then it gets too awkward to deal with. And you can talk about that in many different areas. And that's just basically a business control. So we're catching up on this business control. And so they're the new expenditures. I don't want to ramble on, but that's how we put it together. So I really want to open it for questions and have you guys poke around, probe around, ask questions to understand or possibly to move resources to different areas. The last thing I do want to point out is on the detail sheet, there's two things I want to point out. On the detail sheet, the one thing that we've done this year is, up until 2 or 3 years ago, there was a phenomenon where we pay for state planned medical costs of our individuals. And you would not see that on any DDSN budget. We paid it, you just didn't see it. And it's such a habit that we lost vision on it. So we're bringing it back into vision and we're getting it on our spending plan. And we have some work this fall to build some controls into those monies in order to make sure that we are paying, we know what we're paying for. And just some initial work, we found money that we can stop paying for. Things that were old, creep, clutter, and noise that we're saving money on. And that's why, and to give you an example, and I'll show you the new look monthly spending or budget execution form. It's not this big complex document. It's four rows. But in July, we spent 56 million in cash, and we spent about 17 million on what we call HHS direct bill services. And some time ago, that was a very small amount of money. People would bill HHS, HHS would pay them, and they would take our 30% match. HHS pays 100%, they get the 70% reimbursement, they get a 30%, they're a wash. They're just doing a service for us, we pay the match. But on our books and records, we only reported the 30% cash. We didn't recognize the 70%. So when we give you a spending plan at 100%, and 18% of our business we only pay 30% on, every year our budget looks fantastic because we're always under budget. Well, we're solving that this year. We're going to give you our cash expenditures every month, and we're going to give you what I call it's a gap. It's basically a wash transaction where we could book expense and revenue to equalize it. I don't want to book expense and revenue because now it looks like we're counting it twice, and so is HHS and maybe CAFR implications. But I want to, on our spending plan, bring that money over so you can see we have $850 million budget. Here's our cash expenditures. here are these gap expenditures I just described, so that you can actually see if we're under or over budget during the year. And the other thing I want to point out on the far right side is I kept the 6.2% FMAP separate from operations, and I kept the 10% separate from operations. And what you'll see there is just an estimation of what it will be. And I think the 10% FMAP may be greater than 42.5 million, but I just left it at 42.5 because that's what we're all targeting on. And if we happen to get more, we'll find something to do with it. But I didn't want to overshoot it and then end up not having it realized. So when you look at all our cash, the 42.5, the additional 2 more quarters of 6.2% FMAP, both 42 million and 22 million respectively, plus our end of the year cash of 54 million. We have a lot of assets and reserves poised to do great things for the system. And if you look at them, the 42.5, we have a good budget for. You take our 54 plus the 22, 6.2% FMAP coming in, you're talking, there's another $76 million. We will need some of that for the IDRD waiver. If the things happen that Lori describes are going to happen, and I believe to happen, there will be rate increases, there will be new services. That will cost money, but we have money to improve services. And so those reserves can support us for many, many years providing these services while we secure longer-term financing through the General Assembly with the help of HHS. Director Kerr is committed to this improved service package. He knows there's some risks in financing, but between all of our FMAP funds, we're going to fund it, and we'll have ample funds left over. So that's the many factors going into this budget. But at the end of the day, what I need in the short term is just if it's okay, the $4 million that we asked for is probably the most critical thing to be approved. And I told you what was going to central office, which was less than $1 million. And the other money is going to be retire legacy loans for Chesco and Charleston for $478. We talked about that last time. Additional cameras for regional centers, $50,000. Obviously, if we need more, we can go up. Non-CPIP improvements for the regional centers of $800,000. What that means is,
That's what I was going to ask.
what that means is, the CPIP money historically has run about $3.5 million a year, 3 to 4 million, probably closer to 3. Historically, we get 4.8 million today in care and maintenance from our individuals who we serve. Basically, a lot of their income over a certain level goes to us to pay for services. That has been kind of the capital budget historically. And since I've been here, we have not spent that because of our financial crisis. So I think what we did was we took the $3.5 million that we're budgeting for CPIP. There's about $300,000 that's currently in the regional centers maintenance budgets, and that's just for crisis response to broken pipes, doors, that kind of stuff. And then there's this in-between thing, which is basically a project of significance that's less than $100,000, meaning we don't have to go get a CPIP because it's less than $100,000, but we want to dedicate funds so that we can do major environmental improvements, rugs, painting, things like that the regional centers don't have money to do, but we don't want to tie it up in a CPIP because we learned the hard way of how hard that is to spend that money. We want to keep the latitude of that money. And last year, our base was $400,000, and they spent it. This year, we want to make it to 1.2. It sounds like a lot of money, but when
I've been in the regional centers. I mean, you know, Salivi, I will tell y'all, the whole thing needs painting. And at Midland Center, I don't know if you've been out there lately, but the parking lots are terrible. I mean, the parking lots are terrible. There's weeds growing up on the side of the buildings, and they need a new air conditioner. I was going to tell you, in their training room, it was so hot, about died. So, you know, I've seen the condition that these centers are in, and they need some work. And I feel like we're justified every dime you put in there.
All total is about $5 million, which just is a couple $100,000 greater than the care and maintenance. And I feel like with the maintenance staffs we have and the engineering staff we have, we can put that to work without being wasteful.
Yeah.
But what we're going to challenge those guys to do is really, if they can put it together more efficiently. I mean, I think we're all in agreement, we could go up. And that goes back to some of the earlier questions as how to fund the general rule I see after being here 4 or 5 years is, Medicaid is a cost-based outfit. If you spend the money and it's a reasonable cost, you will get it, but you will get it down the road with a cost increase. So I believe the investments that we make.
I have a question, and this Rufus may have to answer this. In our regional centers, I didn't see it when I was at Salibi, but, and obviously I haven't been able to go in the others yet. When the nurses see a patient, are they taking their notes on paper, or they have computer terminals where they're doing it like they do in the hospitals now?
We actually have an electronic healthcare record, their app, so the information is put into their app. And actually, at Coastal, in the next couple of weeks, we'll be demonstrating telediagnostics, and it'll be a portable med pod that can actually, house tons of analytics relative to vitals and other healthcare data, that will be input by nursing and maybe even some unlicensed personnel once we get the training and show the functionality of this equipment.
I just want to make sure that, I know that's where medical documentation is going. And if we're still doing it paper and pencil, we need to look at other means for that kind of thing.
And Brown, and add to what Rufus is saying, Brown University will be helping to consolidate that data.
Okay, good. Okay, I'm sorry, Pat, go ahead.
So that's the budget, and there's a couple of what I call contingent costs down the road. You guys have, I think we've talked several times about a incident management system, things that our risk division and policy are engaged with HHS about. I think everybody wants them. They're kind of working out the details of how to do it, who to pay for it. So I don't have any hard numbers or even who owns the liability, but that could be coming. We thought about implementing Cronus at the regional centers, which I believe will save us money, it'd be efficient. I just don't want to pull the trigger until events, the water's flatter, because there's too much else going on. But if everything works out, next February, we might come back and ask for Cronus. All right, so with that said, I would like approval to move forward.
Yes, certainly.
This is directly related, but it comes up because it's in here. The 4 investigators for A&E cases.
I forgot, yeah.
I think it's fabulous. They're going to be focused on the regional centers, but where do they slot in organizationally? Would that be part of internal audit? Would that be under the regional center director? Because
my understanding, I'll let Rufus correct me, is I believe they need to be assigned to risk, and I think risk needs to take quality management in the short run to maintain the independence and objectivity, and when things get normalized and quality management has been eroded because people are too busy putting out fires to do quality management. So they need the protection of a central office program to reconstitute them, because their work is important. It's just sometimes they get pulled in so many directions. So I think adding that person as well as entire quality management for multiple years until we stabilize is the direction to go.
Thank you.
Rufus?
Other questions?
The budget from 2021 to 2022 increased by $39 million. How is the Dean County legislator going to look at that? Will we tell them next year we're going to increase 39,000, as soon as we get a surplus, we're going to be letting somebody with our hand out?
Well, it is what it is, because, and most of it is appropriated money. And only 4 million of it is coming from our reserves. And I think when you look at what coming reserves, I think they're, other than one procurement officer, they're all non-personnel things to reconstitute an agency that has been financially strained for a long time. I think where, as an appropriator, I look at it is, you compare us to last year we didn't do a great job at factoring in the HHS wash transactions, which showed us like $50 million under our budget. And that was because we didn't calculate that right. And this year, I mean, the very first month, we did all this without even thinking, without even planning it, but when we took July's expenditures, of which we paid the 30% on, and took the difference and plugged it in, it shows us we're right on track with our budget. So we will, the 800,000, we're an $850 million organization. There's no doubt about that. It's just that historically, these 30% matches have we understated our revenue and expenses because we're only recognizing the cash transaction as opposed to the entire transaction. But all increases are appropriation except $4 million. And when we go forward for our legislative budget and we're sitting on these funds, I mean, obviously, it's based on need. And I think our strategy going forward, we have to work with you, but my initial strategy would be, look, we have plenty of non-recurring money. What we need to do is get recurring money for the new IDRD waiver. And that should be our strategy. And part of that could be returning funds for, we may find out in a month or two that even with these increases, unless you raise DSP salaries to $15, we can't get anybody. So who knows what's going to happen? But we have plenty of of non-recurring money. We need recurring money, and our strategy should be to go for recurring money and give them the non-recurring money.
All right, other questions?
I would just ask that we would, well, I'm pretty much ready to make a motion, but except to say that I think that that the staff and particularly this commission needs to be commended for going from $158,000 in the bank in 2019 in June to what we have now. It is remarkable, and COVID is part of that reason, I understand, but the fortitude of this commission has been wonderful, and the lack of fortitude in the ones before have been sad, and I would just like to commend the commission on that. The only thing is, this is the same plan that you brought before the finance committee, correct?
Yes.
Correct. Okay. Well, then the only other thing I would ask is, do we want to add, if needed? Now, I understand it may not be needed because it may depend on who we currently use as a provider for this purpose. But I mean, as a person that procures this purpose, but do we want to add the 40 to 50,000 in that we may need to correct our video system to be able to hold more than 60 days of viewing?
I thought it was going to be like 400,000. How much was it?
50,000 is what I was told at the finance committee.
I'll tell you the answer to that question. And Mike, be quiet.
All right.
It confuses things. What I found out was, after talking to Kyla, early on there was, hey, we got to build this, we got to build a roller system, build a server, pipe stuff in. And when I spoke to Kyla, when I built this budget, she was saying that she was seeing the vendor has the capabilities through literally an app to pipe footage from all the centers to her desktop. And the vendor has the capability to sell us cloud storage for more time. So after I heard that, and I heard Mike, and I trust Mike implicitly, and Mike would do a better job, but before we make a decision, I think we have the regional center group, and the regional center group really needs to get Kyla to really dice out what is the cost, not only what is the cost, what's the quality, what's the risk, and then we compare that to what Mike can do it for, and we may need a $50,000 capital improvement a month or two from now. And when you build this budget, what you see is anything I consider like new. I'm giving you to be transparent, but we got to forget we still have, from a central office perspective, we still spent $5 million on IT last year. We have funds available for, I would call it, recurring things. So 50,000 ain't gonna break his budget. It could come from within. But I just don't want to commit capital project until we're sure what the vendor can and can't do. And then at that point, we can make a good technical decision as to, hey, do we want to bring it in-house, or do we want to, pay the vendor $5,000 for cloud storage, of which, if we can't get it, or we feel like it's not reliable, or any of those issues, we can always take it in-house. But I can't commit to that right now. But we have plenty of money to commit if you so choose.
Well, I think however we do it, we do choose to do it. So we want to make sure that it's done as soon as possible because we don't want to lose any incidences that we may have at some point in the future.
Colleen needs 100% authority to go search out what her requirements are and either have the vendor fill them or give them the mic and we'll fill them. We got to button it down.
All right, well, do we need a separate motion to make
That'll
that?
come later. What we'll do is, we'll finish this report, and then we'll make a motion
Yeah, well,
after that.
separate motion, that's fine.
You see what I'm saying?
Yeah,
To do that separately, to have that begin, that process. Okay, go ahead. All right, what is the pleasure of the commission?
I make a motion to approve the spending plan as presented.
Okay, do I have a second?
Second.
All right, any further discussion on this matter? We've discussed it out. Hearing no discussion further, I will ask that all in favor, please signify by saying aye.
Aye.
All opposed, nay. Abstentions? Being none, the ayes carry, this funding plan is approved. All right, financial update.
I only have the, give me a second here. I have the one chart, which is your new and improved spending plan versus actual. And this is what you'll be seeing every month as opposed to all the other charts. And the reason we're doing this is we're trying to bring in our cash expenditures plus the HHS wash or wedge or gap money so that you have a true picture of what we're spending every month that matches the spending plan. And so you can track that deviation as it goes through the year. After the first quarter, we will start adding revenue to this so that you can start seeing the revenue track. The thing about revenue is we got to make sure that there's about 4 or 5 anomalies during the year where there's either excessive more expenditure or less expenditures. And we want to make sure we chart them out so that when you see a year that blips, when you see a month that blips up, it answers the question before you ask it. Like there's a particular time of year we make a deposit to, I think Medicaid or HHS of a large amount of money. And that would cause that month to be swayed. What I want to do is chart that out in advance so that when we see those things, people would expect them and not be startled by the jump. So give me till October 1st on that. And the only other things I want to bring to your attention are,
And while you're looking for it, I see the word reasonable. When are we to get along?
what's that?
When are we to get along? I see your word reasonable.
Yeah.
That's a good word.
Yeah. We can fluctuate up and down a little bit. I think when it starts fluctuating way too high or way too low, we got to find out why.
Right now, we're within reason.
It's within reason. Number 2, the 60 home legacy issue. We met with all the providers on August 4th. No promise has been made as to how we'll work that out, other than we have the General Assembly proviso that we will maintain maintenance on these 60 homes. During that conversation, they all seemed reasonable, and the first course of action was to do an inventory of all 60 homes for any improvements that fall into, kind of the structural maintenance of the home, roofs, fire and safety, major appliances. Andrew has been out there. He is, of the 60, he's been to 14. He's going to 4 tomorrow. So I hope by the end of September, we'll have an inventory of what we think is the improvements needed to get them to a level that could potentially be a jump-off point as to somebody taking over the maintenance of it. I'm sending a memo. It's about a week delay, but I'll have it out by tomorrow. And I asked anybody out there, I said, look, some of these costs that could be accruing from July 1st, we own. I said, if anybody has any cash flow issues, call me and we'll pay for them right now. No one took me up on it. So I think they're just going to collect them. Andrew will do his thing, and hopefully by early to mid-October, we'll have kind of a picture of what's the liability look like out there. And then going forward, I think just informal discussions with many of them. I think they may find ways to, instead of fixing up, these are really older homes because they're all early 90s, that they, instead of fixing up a home with, $58,000 a new roof, we may be in a position to where they will flip that property, go buy a new home, get a housing trust loan for $100,000, and we can maybe take that same money and roll it into a new home and So I think there's a lot of those options to liquidate as many as possible, but we may not be able to liquidate all of them. And at the same time, once we get them to a stage, I felt there was a hope that they would take over all the maintenance from that point forward. Nothing's been negotiated, but we just got to get inventory, and everybody seemed reasonable to get that inventory. And then between now and then, I think this has to be a discussion for the Finance Committee and individual commission members so that we get some direction on how to carry out the will of the General Assembly and be reasonable in how we bring this to a conclusion.
Okay. Sounds good.
10% FMAP, the latest is, as of last week, CMS got a hold of HHS, and they wanted some more information. I think they gave them maybe some partial approvals, but nothing came to us. And HHS is going to meet this week internally and get back to us. But at least CMS is looking at the budget request, so I think there's movement, but nothing's popped out that we could execute yet. And that's the latest on that.
Okay.
That's all I have.
Thank you, Pat. Do we need a motion to approve the financial update? We received it.
Yes, we do. I so moved. Well, we did.
Oh,
Yeah, sorry,
that
not
was
the update,
spending-
that's right.
that was a spending
Spending
plan.
plan, sorry. I'll make a motion that we approve the financial update.
Do we have a second?
Second.
All right, all in favor, please signify by saying aye.
Aye.
All opposed, nay. All abstentions? Hearing none, the ayes carry, the financial update is carried. Okay, is there any other new business? Barry, I think you said you had something?
Well, I did, regarding what we just brought up in the finance, from the information we just had, that we would make a motion to do whatever was either $50,000 or less, whatever is necessary to upgrade our videos so that we can have all 180 cameras to be more than 60 days long.
I think we need to see where incidents are and make sure that we pull any incident for the last 60 days at least.
Right.
And
I would say probably 90.
Camera.
We want to keep it at.
Yeah.
What could we keep it at, rather, if we're, Mike, if we're able to either do this by the $50,000 or by the vendor?
Right now, it's built for 60 days, and we would have to do an assessment to see what 90 days would take. So there isn't, the vendors are currently looking at the systems right now to make sure that it's in good health. But if we do want to talk about 90 days of storage, we would have to do an assessment to get a number for you. The $50,000 was to take any excerpt or full day's worth of video off of the system and house it here at central office in the event there's an investigation.
And I think that's my concern is, we need to make sure, we don't necessarily have to keep the whole day of 90 days, but if there's an incident reported, I think we need to make sure a video is pulled of that incident. Because if we wait 60 days and then there's something comes up after 60 days with that report, we can't go back and get the video.
Right, and some of this has to be, the people in incident management have to take responsibility and realize
And get it
that we gotta
immediately.
get it
Get
in
the
before 60
video,
days is up.
yeah.
Like,
And I think that's reasonable.
Are we talking about, clarify for me, Mike, I'm sorry, I may have misunderstood. Are we talking about two different systems here essentially?
How about this?
Let me just finish, Pat, real quick, if you don't mind. Was it, we've got one thing that we're paying for cloud storage and then another one for bringing it here to the office to review? I guess I misunderstood what you just said there, Mike.
Well, we have 5 different camera systems, and all of those camera systems are at each center.
Right.
And if there was an investigation, 50,000 came out of a conversation recently where they wanted a full day's worth of footage. And we couldn't support that from an IT perspective to pull it off.
Right. We didn't have the ability to bring down a full day here to central office where a full days could be essentially stored on site here. That's correct. Okay, that's one system. We're talking about a separate system then of maintaining the data for 90 days out there somewhere else other.
So the systems, the 5 systems I just mentioned, if you're interested in 90 days, those systems would have to be upgraded.
Right. Okay, so we are talking about 2 separate systems here.
Yes.
Right, okay, and I don't think that's being clarified in the.
The answer is no, we're not doing that. What we're doing is, we have to figure out what our requirements are. Okay, so we're already jumping ahead with the solution phase. Let's stop the requirements are, what do I need? And then we already have a vendor who already has been doing this full-time. They already have capabilities to pipe it in. So I don't know what their capabilities are, but the first step is build your requirements, go to the vendor and say, what is it gonna cost me? And then they will do what they do, Mike will vet it, and then we may make a decision like, hey, we can do it either cheaper in-house, or it may not be cheaper, we feel like we have quicker access, but we need analysis before we need decisions. So it all starts with what are requirements, go to the vendor, do the hard work, ask the hard questions, get the answers, and then we can make a decision as to what do we do. So I think we skipped that first spot, we've gone to the second without thinking through the first, so we got to go back to the first. And so I think it's a policy risk issue to go to the vendor, Mike can sit in the passenger seat and decide what the requirements are and see what the costs are.
I think, the commissioners I've talked to, the concern is that these incidents are common and they're not pulling the tape in advance. They're not going ahead and getting the tape no matter what it is. I mean, they may say at the regional center report saying it's nothing big, she fell, but in actuality, it was a true incident. And we want to make sure we have the tapes of that. So I think the problem is we want to make sure if there's an incident report filed here at DDSN, that we have whatever the incident was. If it was videoed, we want the videos.
You can go to 120 days for a year, and after a year, you say, you know what, we only used it once, and it's costing too much.
Yeah.
Or 120 days may not cost as much.
Well, I think if I were doing the motion, I would try to ask that they go research, that our people in QA go get us, tell us what the capacity of the system we currently have is, and be able to bring us back a reasonable method to do what we're asking. Am I correct in assuming that's what y'all want, is y'all want the videos of the incidents
Right.
held?
Yes, but right now, we know that we have 60 days.
Right.
So that's not an issue.
But somebody could come back and file at 90 days, and then what you're gonna do? We don't have any video of it.
Right, but we can't make it an endless, we just have to figure out what 90 days would be, and then,
Right.
and then people in quality.
Commissioner. Hang on.
Yes. This is David.
Okay.
This is David. Just a quick question. I thought the cloud was the answer to everything relative to, this is my way of thinking about this kind of stuff, but I thought the cloud was the answer to everything relative to storage. Is that even yet a third way of doing it?
We can't afford cloud for all of the cameras that we have. The cloud is really good for solution services that you buy. For instance, TheraP, that's a cloud solution. But over 600 cameras in the cloud, that's just not viable.
That doesn't work. Mike is absolutely correct. So what we should do is let Mike go, do his homework, bring it back to us.
I think Kyle is gonna have to bring us some information too, because she's the one that manages the other group, right?
But then we gonna give the responsibility to both or one, and then bring it back to us.
I think they're gonna have to work together. Come up with a solution that'll.
Operators will set the requirements, what do they want?
Okay.
And then once they set the requirements, they can get a price package. Mike can quality control the price package.
Right.
And Mike can say, I can do it better, cheaper, and then we decide.
Right.
I think one of the parameters needs to be is that if there's an incident report filed, we want the video for it. We don't want there to be an incident report and no video. If an incident report is written at a regional center, that video needs to be sent to DSN. I mean, that should be one of the parameters, period.
And I think as we've done in the past, the system is always designed by the policy.
Sure.
So if there's any changes or additions that you want to the investigation or whatever, they will build the system around the policy.
Right.
So we'd have to look at that as well.
That's fine.
That's right. You can build a system around the policy, but we gotta figure out exactly what the policy be without being unrealistic. We can't keep a year, so we can't be unrealistic,
But you could keep incidences, you could keep individual incidences for a year, am I correct? Maybe not keep a whole year's worth of data, but specific incidents.
One day.
Yeah, or,
You can preserve the data.
yeah.
Right, we could preserve, and the point, I think the point is the majority of this commission, I would never say all of us, because I would never say all of us for anything, AKA what happened earlier, but what I would say is that the majority of this commission wants to not lose any incident video that we may need at some point. We do not want anybody to say we don't have it any longer, based upon what's been going on in the past couple of years regarding incidences.
I agree.
And there, again, I think there's two separate issues. You have preservation and access, right? Those are the two elements to it. We want to maximize preservation and be able to have legitimate access to it. That's where I think we're at.
So much immediate access.
Yeah, let me ask a question. So does Kyla have immediate access to that to those videos? Or does she have to get it from the administrators at the facility?
No, we most recently restricted access to all the camera solution systems and has given it to people in the agency who needs it, including Kyla and her team.
Okay, good.
They can go back and look at video as long as it's on the city, the system.
Okay.
And if they need it extracted, they call IT.
Good, okay.
that's good.
We just want to make sure that she could get to it, not have to wait on somebody to send it to her.
Previous to that, there was a number, I think we had about 40 people who had access to all the systems, and we've reduced that significantly over the last 2 weeks.
Okay, great. All right, anything else? All right, we got a motion, and Barry, you want to reword it, or?
Yeah, I do need to, I need to play the tape to figure out how to. I'm trying to say that we need a plan to decide how we're gonna hold the video information that we need, and we expect a plan to come back to us next month. And
Yes.
how we're gonna do that, and exactly what that's gonna cost for us to do, so that we can move forward in preserving whatever incident information we may need in the future.
And you have to make sure that
I
what,
don't think it would hurt.
but you have to make sure that what Gary said have to be somehow included, because you're dealing.
We need preservation information and
Right.
legitimate access information.
Correct.
Added to that.
Okay, we need preservation and legitimate access information, I got it.
Correct.
Second. All right, we got a motion and a second.
You have the motion, Christie. All right.
Any further discussion on this matter? All right, all in favor, please signify by saying aye.
Aye.
David's gotta go very soon.
All opposed? Hearing none, the ayes carry, and we will look for that report next month from you folks on that. All right, is there any other new business that needs to be brought before the commission? All right, hearing none, our next regular meeting will be September 16th, 2021.
Make a motion to adjourn.
Okay, and do we have a second?
Second.
All in favor, signify by saying aye. All opposed, nay. The ayes carry. Thank you. Thank you all for tuning in.
Sorry.